Okay. So it's the Bill and Anthony show today, so I'm sorry if you have to listen to me 3 times. Try to make the first one good so you won't fall asleep the other times. So we're going to talk about endometrial cancer in early stage, more as a basis for how to discuss things with our gyne-onc colleagues. I have disclosures. I'm on the Carl Zeiss Speakers Bureau, and I have a Merck Advisory Board, none of which means anything for this talk. There's no disclosure for this talk. What I'd like to do is review the histology, staging, and risk factors for recurrence, obviously for early disease, review some patterns of recurrence, evidence and rationale for adjuvant radiotherapy, discuss patient-centered discussion and risk-benefit of adjuvant radiation, endpoints of adjuvant brachytherapy, some heterogeneity of stage 2 patients. I'm just going to touch on sentinel nodes and discuss recently reported clinical trials because I think they may or may not change what we do. But as you know, endometrial cancer is a really common problem and just getting worse probably because of the obesity epidemic. And there's at least 62,000 cases per year in the state. It's the 4th most in the United States. It's the 4th most common cancer in the U.S. There's about a 2.5 time lifetime risk that has been increasing, and 97% of the cancers are typical endometrial carcinomas. Most of the remaining are sarcomas, and I won't really touch on that. That's really obviously very controversial. So it is a very common cancer, and we think of it as very curable, which it is, but it has almost as many deaths as breast cancer. There's 24,000, almost as many deaths as pancreas cancer and other cancers. So it isn't that easy or that good of a disease, especially in the later stages. I think this is where we're going to go. We're not there yet. We're very behind in gynecological malignancies with targeted agents and molecular-driven therapies. I think this is where in the future we're going to start to figure out how to treat endometrial cancer a little bit more smartly than just stage, grade, histology. We're not there yet. I just want to touch on this, that this may be where we go from in the next 10 years. And remember, the staging system changed in 2009, so some of the older articles have a different staging system. And when you have you're at the end of this talk, when you push a button, remember that 1C is no longer part of the staging system. But old staging system was 1A, 1B, and 1C, non-invasive, invasive to half, or invasive greater than half. I actually don't like that change because I think of non-invasive endometrial cancer different than invasive endometrial cancer. So when I stage patients, I'll say stage 1A non-invasive, just to kind of differentiate it, even though that's not part of the staging system. And they did change 3C into 3C1 and 3C2. I wrote a very obscure paper 25 years ago suggesting that, so I'm sure that's why it happened. And I do like that change. I do like getting rid of your cytology as part of the staging system, but again, should always look at it. It does make me change my treatment on occasion if I think it might be real. So there's a few different staging things, some of it good, some of it bad. And again, those are the differences. So adjuvant radiation for early stage is very contentious. I don't think it's changed much over the years. I was at the first NCCN committee meeting for endometrial cancer, and we had half the group who treated almost everybody and half the group who treated nobody. And that's why those original NCCN endometrial cancer evidence-based tables look horrible because no one could agree with anything. So I'm not really sure we've changed much, but it's really still, I think, a very contentious issue. But there is some rationale for adjuvant radiation. Every stage patient with adverse pathological features are at risk for extrauterine disease and recurrence, and the most commonly cited pathological factors include myometrial invasion, tumor grade, cervical involvement, age, lymphovascular space invasion. And the importance really was seen in GOG 33. And GOG 33 was a surgical pathological study of 621 patients, all clinical stage 1 patients, showing grade and myometrial invasion correlating with positive pelvic and periaortic nodes. It's probably better to look at it this way, and this also might be when you're pushing a button something to remember, that grade and depth of invasion in GOG 33 showed a correlation for positive lymph nodes. I think that comes into play a lot when you're making decisions to give adjuvant radiation in a patient that didn't have lymph node dissection. So patients with grade 3 disease, let's see if I tried, there we go, grade 3 disease and deep invasion has a pretty high incidence of pelvic lymph nodes. And also remember, there's a fairly high incidence of periaortic lymph nodes. So when you're treating someone with endometrial cancer, we'll talk about that in the advanced disease discussion. If they have positive pelvic nodes and did not have a periaortic dissection, you at least have to think about whether you're going to treat that. because there is a fairly high incidence of periortic metastases in patients with pelvic metastases. And this is a study we did at our old institution at Northwestern, just showing that if you're also on the border between giving pelvic radiation, that the size of the cancer may play a role. So this is lymph node metastases based on size. Smaller tumor size has less, bigger has more, and if you combine that with depth of invasion, you can have some evidence of whether you should treat the pelvis if there's no pelvic lymph node dissection. So that, I don't use size as a major risk factor in my treatment decisions unless I'm deciding whether to give pelvic radiation. And again, it's most common for tumor grades, so tumor grades greater than 2 centimeters had a reasonable evidence of lymph node metastases. So sometimes I'll use that when I talk about giving pelvic radiation. And then, of course, cervical involvement and capillary space involvement have an increased risk of pelvic lymph nodes. So all these things you kind of put together when you're trying to decide whether to give pelvic radiation for early stage endometrial cancer in the absence of lymph node dissection. And there are a couple things that people use. This is a risk scoring system for individualized prediction of lymphatic dissemination in patients with endometrial adenocarcinoma, and it was published by the group at Mayo, who's done a lot of work in predicting lymph node metastases. It's published in Gyne-Onc in 2013, and it's one of these simple things where you look at points, percent of myometrial invasion, primary tumor size, FIGO grade, cervical stromal invasion, LVSI, and it predicts the probability of lymph node metastases. Maybe something to use when people don't get lymph node metastases, whether you're giving pelvic radiation. So I have occasionally used that. This is the same thing without the size, because that's probably the weakest thing to use. So something to consider. If someone doesn't have a lymph node dissection, what do? I get imaging, and I look at these risk factors and decide whether pelvic radiation is warranted. And this is simply another nomogram, again, looking at predicting lymph node metastases in presumed stage 1 or 2 endometrial cancer. And I won't belabor the point, but again, it looks at these various factors, including age, depth of invasion, biological subtype, race, grade. Everyone does this a little bit differently, but at least those two may give you something to look at if you're deciding on whether you should give pelvic radiation. And I was born actually before this study came out, but I don't think we've made much progress since this study, to be honest with you. This study is from 1965, and it looked at 41 clinical stage 1 patients undergoing surgery alone. And it looked at grade and myometrial invasion and vaginal recurrence rates. For all these patients, it was 14%. Keep that in mind. These numbers are pretty consistent over all the articles you look at, and we're just going to touch on the major articles when we're looking at things. So we talked about when you might give pelvic radiation. Now we're going to talk about just recurrences and when you might want to consider radiation. So what evidence supports the use of adjuvant radiation, stage 1 and 2 endometrial carcinoma? There's been a lot of studies. We'll talk about a lot of these, but the Norwegian Adler study, which was published in 1980, decreased local regional recurrence rates from about 7% to 2%, Portec from 14 to 4, GOG from 2 to 3, ASTEC EN2 and Portec 2 we'll talk about. And I'll talk about these numbers in detail, but remember that 1965 article was 14%? Not sure we made a lot of changes since then. So the Norwegian trial, it's an older trial, but I think still has some interesting points. It was clinical stage 1 patients. 540 patients were randomized. Everybody got a hysterectomy, but without lymph node sampling, and no assessment of peritoneal cytology. It wasn't a randomized trial of radiation or not. It was a randomized trial of vaginal brachytherapy plus minus external beam radiation. And you can argue that this external beam radiation, not the best probably. 40 gray with a central block at 20 gray is not the most sophisticated treatment in the world. And the second arm was no further radiation. And pelvic radiation, despite its not great technique, reduced vaginal and pelvic failure rates in patients with high-risk features. Deep myometrial invasion, grade 3, which makes sense because there was no lymph node dissection. So these patients, if you remember GOG 33, had a fairly high risk of having pelvic lymph node metastases. So in grade 1 or 2 tumors that would have less of a risk because they're not as deep and non-deeply invasive, the radiation didn't do much. Even with a greater depth invasion, it didn't do much. But with grade 3 tumors with deep invasion, no RT at about a 20% risk of recurrence versus 4%, no external RT. So deeply invasive grade 3 tumors were improved by adding 40 gray of radiation. There was no survival benefit in the trial, but patients with deeply invasive grade 3 tumors had a reduced death from cancer by about 10%. And what they started, when they did this trial, lymph vascular invasion was just starting to be thought of as a risk factor for endometrial cancer. And they did look at the last 150 patients on the trial, and vessel invasion was seen in 20% of those patients. That's pretty consistent across a lot of these tumors, that for endometrial cancer, about 20% of patients will have LVSI. Local recurrence rates in those patients were 21% with no pelvic RT versus none in the pelvic RT group. So it was a predictor of lymph node metastases. It was a predictor of recurrence. And their conclusions, which I'm not sure we've changed over the last 40 years since this was published, was grade 3 deep invasion gets pelvic radiation, all patients with LVSI receive pelvic radiation, and all other patients get vaginal brachytherapy. So at least it started to quantify the data we talked about in GOG 33, that if patients do have deep invasive grade 3 disease, they have a pretty high risk of pelvic recurrence, especially in the absence of lymph node metastases, or lymph node dissections. Which brings us to the PORTEC trial. The guys in the Netherlands do a great job with these trials. It's a post-operative radiation therapy and endometrial carcinoma, PORTEC, and this is PORTEC 1. And the selection was grade 1, greater than 1/2 myometrial invasion, and this is clinical stage 1 again, grade 2, any myometrial invasion, or grade 3, half myometrial invasion, less than half, because they treated all deeply invasive grade 3 tumors, because we've talked about the data of the risk of having pelvic lymph node metastases. There were 715 patients in this trial. Again, no lymph node sampling in the trial, all histologies. The regimen 1 was pelvic radiation, 46 gray and 23 fractions with no vaginal brachytherapy. Regimen 2 was no further therapy. So this was the first real randomized trial of radiation or no radiation, because the other trial had vag cuff versus pelvic and vag cuff. And then they did a post-op analysis, and ad hoc post-trial analysis are only good if they support your conclusion, because if you talk to a statistician, they'll never want you to do it. But they did it, so did GOG 99, and they have a high intermediate risk definition, which was 2 of 3 of these factors. And remember that grade 3 deep invasion was not in this trial. Age greater than 60, grade 3 or invasion greater than 50, based on invasion less than or greater than 1/2, age, FIGO grade, and high intermediate risk group, which we talked about. And this, you can see the slides here. And what's interesting in this slide is if you look at grade 1 or 2 did about the same, which we'll talk about GOG 99, which is a different animal when it came up to grade, how that was looked at. Grade 3 did worse, high intermediate risk did worse, age holder did worse, invasion did worse, but not by much. And the 10-year outcome, this is with pathological review, because when they went back and looked at a lot of the specimens, they changed the grade on the specimens. So some of the patients would not have been eligible because they were low risk. They were grade 1, less than 1/2 invasion. So if you look at all the patients, 10 years, local region recurrence actuarial rates was 14 versus 5%. So about 10% difference. That's another thing to remember. About 10% difference, and you'll see that in the GOG 99 trial too. If you excluded the stage 1B, remember this is the O1B, or the less than 1/2 invasion, which was 134 patients. So remember, it was a fairly big trial, but this is a lot of patients that they restaged and regraded. The trial even was more positive, 17 versus 5%, about 10% difference in local regional recurrence rate with the addition of pelvic radiation in a relatively low risk group of patients. And they keep publishing this data. So this is pretty mature data. They published it again in JCO in 2011 with their 15-year outcomes, with a median follow-up of 13.3 years. This was buried in a toxicity article, and we'll talk a little bit about that. Local region recurrence rate, actuary rates, 15.5 versus 5.8, about 10%. Pretty consistent. So the local region recurrence rates were improved by about 10% in PORTEC 1. But the cytolocal region recurrence rates, and this will come up, and this might be something else you'll push a button for, was 75% of the local regional recurrences were isolated vaginal recurrences. So a 10% difference with 75% being vag cuff. So the thought of whether or not we should just be treating vag cuff obviously is supported by PORTEC 1 and the reason for PORTEC 2. If you look at GOG 99, that was the other big trial that was happening about at that same time. It was stage 1B or 2 occult, meaning not gross cervical involvement at the time of surgery. Papillary serous and clear cell were excluded. About 400 patients randomized. Difference between this and PORTEC 1 is that lymph node dissection was in this trial, and they did assess peritoneal cytology. Regimen 1, simple randomized trial, 50.4 gray with no vag cuff versus no further therapy. With a median survival, with a median follow-up of surviving patients being 68 months, the 24-month cumulative incidence of recurrence was 3% in the RT group versus 12% in the no additional therapy group. Pretty consistent. And remember that 1965 article, 13% recurrence rate. I'm not sure we changed much in all these years, but so it's pretty consistent recurrence rate without radiation in these relatively low-risk patients. And 13 of the 18 local region recurrences were in the vaginal vault. So exactly the same data as PORTEC 1. 75% of the recurrence in these low-risk patients were in the vag cuff. And then they just isolated more. This is cumulative incident recurrence of isolated recurrences. The survival was essentially the same. And strangely enough, there was more toxicity in the RT group. I've never had any toxicity, but I hear some people have had toxicity, but they had some toxicity. And GOG 99 also did a post-hoc analysis, which was a basis for the next trial, which was GOG 249, which we'll talk about. They had a high intermediate risk group. Advanced age, and as I get older, I don't think this is really advanced age. What's young, my age and younger. So high grade, which they included grade 2 and 3. So that's a little difference. Remember PORTEC 1, grades 1 and 2 did about the same. So it's an interesting. Outer 33% myometrial invasion. I do think that's important. I do think as the tumor gets closer to the outside of the myometrium, there is a denser lymphatics, and I think that the risk goes up as it gets farther out, or lymphovascular space invasion. And you needed one factor if they were 70 and over, 2 if they were 50 to 70, and all 3 if they're under 50 to be in this high intermediate risk group. And again, post-hoc analysis, if you talk to statisticians, you can always find something, so take it with a grain of salt. But there was a significant improvement in recurrence with the addition of radiation in this high intermediate risk group, from 27% to 13% with a hazard ratio of 58% hazard reduction. In the high intermediate risk group was 33% of the patients, but was 2/3 of the recurrence rates. And even more interesting, if you look at survival, and again, these kind of analyses are only good if they support what you want to do. The survival in the radiation group was 88%, and 74% in the no radiation group in this high intermediate risk patient. So it was an interesting concept about what to do about this. And this is a slide that I use. So this is just the risk groupings between the two trials, what they decided was high intermediate risk. Again, PORTEC 1 was greater than 60, grade 3 or greater than 50% myometrial invasion. Remember, they excluded the deeply invasive grade 3 patients. 2 out of 3 were considered their higher intermediate risk group. And GOG 99, what we just talked about, grade 2 or 3, greater than 66% invasion or LVSI was present, and that how we did it with the age. So PORTEC did not look at LVSI, which I think is kind of a mistake. So these are two groups, they're not quite comparable. And again, I think if we do this talk 5 years from now, it'll be molecularly targeted, molecularly driven, which is what it should be probably. And then this is the groupings. So again, kind of the post-op pelvic RT for PORTEC 1 and GOG 99. In the intermediate risk to increase local regional recurrences from about 12 to 14% to 3 to 4%, so 10% reduction. In the high intermediate risk group, there was a much bigger improvement, anywhere from about 20% to 5%. And the lower intermediate risk group was about 6% to 2%. So there was an improvement. These were positive trials for radiation, whether they didn't show much survival advantage, but they weren't powered for survival. And again, the site of local regional relapse was 75% of the time in the vaginal cuff. So pretty consistent message between these two things. There was the MRC Aztec NCICEN5 trial that was done. I won't talk too much about this. This was an interesting trial. It was adjuvant external beam radiation, the treatment of endometrial cancer, randomized trial. And it was randomized between no external radiation or external beam radiation. And these were the patients that were in there. The majority of the patients were grade 2 deeply invasive disease. But it was kind of an interesting trial. I'm going through it kind of quick because I don't think you really have to know this much when you're treating your patients. But brachytherapy was allowed. Well, if you wanted to give brachy, you give brachy. So it wasn't really radiation versus no radiation. Centers can do it anytime, whoever they wanted. They just had to decide if they were going to give brachytherapy for these patients. And they, even though it was supposed to be for low risk group, they were still eligible if they had positive lymph nodes. It was kind of hodgepodge technique. The Aztec trial, again, it was 2 trials that came together, gave 2 fractions of 4 gray to a half a centimeter, 15 gray to the upper third of the vagina for low dose rate. EN5 was whatever you gave, you can give. So kind of a loose association of what to do in this trial. About 905 patients were randomized. 98% of the patients in the no external beam group didn't receive radiation, but 51% got brachy in each arm. Most of the patients in external beam radiation got radiation. Pretty balanced. I won't go into this detail. But one other thing that I thought was interesting, only about 82% in the post-op pelvic radiation arm actually got at least 40 gray. I've been treating for a long time. I can't remember the last time I couldn't get someone through pelvic radiation. So this is a very strange trial that didn't give really great pelvic radiation. And of course, there was more toxicity. There was no difference in survival. But it was a positive trial. There was a 3% difference in 5-year cumulative incidence of recurrence that was statistically significant. Whether it's worth it, it was 7% versus 4%. But because this was such a strange trial, it's hard to even know if that's radiation or not. Half the patients got brachytherapy, and the 5-year cumulative incidence of recurrence, again, was 6.1 versus 3.2%. Positive trial, whether that's clinically significant, who knows. But what I thought was interesting, I stole these slides from the presentation at ASCO, or I borrowed them, and they didn't appear in the paper. If you take the patients who got brachy and external beam radiation that may have actually gotten real treatment, there's a significant trend towards an improvement in survival and improvement in recurrence-free survival. So I just mentioned this, that although this trial wasn't really that positive, it was such a hodgepodge of patients, it's really hard to make much conclusions from it. But when patients got probably a good dose of radiation in the vaginal cuff, they did okay. But then there was a meta-analysis looking at these 3 trials saying, because there's no difference in survival, you shouldn't give it, which I think is the most ridiculous thing I've ever seen. None of these trials were powered for survival. There were groups of patients in these trials that probably benefited. And I like Michael Berman a lot, and I use this slide and hope he's never in the audience because I don't want him to hear me say this. So I think there's a myth that isolated vaginal recurrences are easily salvageable. People say, we'll just salvage them if they come back anyways. So the editorial that accompanied GOG 99 said, yet vaginal recurrences usually are treated successfully with radiotherapy in a patient not previously treated with adjuvant radiation. If you look at the publication, 12 of the 13 patients in the no additional treatment arm were treated with salvage radiotherapy, and the crude observation were 5 of the 13 died of endometrial cancer. So I don't think that's easily salvageable in my head, even from that group of patients. That's a pretty high rate of death. So not so sure. Not so sure salvage rates are as high as those as are commonly quoted, which a lot of our gynec colleagues will quote 70%. I do not. Most studies don't support that data. I think the typical survival rate is about 40 to 50%. And there's poor outcomes, obviously, in non-vag cuff recurrences. And this is the data that I can come up with, a bunch of different locally recurrent endometrial cancer series. The one by Hofstra in 1993 was ours. The local recurrence rates, local control rate of salvage for vag cuff recurrences, anywhere from 35 to 77%. Survival all over the place. I think 50% is a reasonable estimation of control. So these patients have a different biology. They recurred. Whether preventing that recurrence would make a difference is another story, but they're not easily salvageable. And the salvage treatment is not necessarily that easy. For those of us that give a fair amount, it's either surgery with external beam, it's brachytherapy with radiation, sometimes adding chemo. There's a randomized trial looking at that that's been going on, Mark, for what, 23 years? GOG 238? It's been open for a while. It's getting closer. But it is certainly toxic to salvage these patients. So preventing vaginal cuff recurrences is probably a good thing. So what's the best RT? I think that if you look at all this data, it's clear that radiotherapy is indicated in high-risk early-stage endometrial cancer. I don't care what our gynae colleagues think. But can vaginal brachytherapy replace these in most of the patients? Because remember, 10% difference in recurrence rate, but most were vag cuff, which led to PORTEC 2 trial, which ran from 2002 to 2006, and it was stage 1 or 2A endometrial carcinoma. Remember, 2A is no longer in the staging system. That was endocervical glandular involvement. So it's probably good that was probably reasonable that that's a difference in the staging system. But what I don't like about this trial is that it would take very low-risk patients, too, because they had glandular involvement in the cervix, which we now ignore. So it's a little bit different, but there wasn't many of those patients. And again, it was age 60 or greater, 1C grade 1 or 2, so again, deeply invasive grade 1 or 2, or 1B grade 3, and then any stage 2A, and it was a randomization between pelvic radiation or vaginal cuff radiation. And the pelvic radiation was 46 gray and 23 fractions, and this bird is a critic of mine, or don't think I've had a talk where a bird flew in before. And it was vaginal brachytherapy, 21 gray high dose rate or 30 gray low dose rate prescribed to a ½ centimeter. And I put this slide up because we've written some guidelines on vaginal cuff brachytherapy, but there's not a lot of data on what to do. Just so you know that they actually treated 46 millimeters, so they treated 4.6 centimeters of vaginal cuff in this trial. One of the few, on average, one of the few trials that actually reported prospective data. So if you're looking at what length to treat, this treated 4.6 centimeters. And this was the results. Remember, this trial was powered to prove that vaginal brachytherapy can prevent vaginal recurrences, not to prove that that was the treatment of choice, not to say that you can avoid pelvic radiation. The vaginal recurrence rates were 1.6 in the external beam and 1.8 in the vaginal brachytherapy arm. So both prevented vaginal cuff recurrences in the majority of patients. I still think 2% is kind of high rate. The pelvic recurrences rate were significantly reduced with external beam radiation. It was 4%, 3.8% versus 0.5%. That was statistically significant. Now, is 3.8% enough to give pelvic radiation? That's up to you. So some of these patients, it was a hodgepodge. I think that saying you don't get pelvic radiation from this trial is not the endpoint. The endpoint is vaginal cuff radiation can prevent vaginal recurrences. And what they conclude is, despite the slightly but significantly increased pelvic failure rate in the vaginal brachytherapy arm, distant metastases, relapse-free survival, and overall survival were similar. And because vaginal brachytherapy is tolerated better, it will be considered the treatment of choice. I don't disagree, but I do think you have to think of each individual patient differently and talk about the risk factors and the risk of pelvic lymph nodes like we did before. And I'll show you a compilation we did to kind of look at that. This is a busy slide. We've gone through it. These are the different adjuvant radiotherapy trials. I didn't talk about the Swedish trial. But again, they all have about the same conclusions. 10% reduction, most vaginal brachytherapy can probably replace external beam in a lot of these patients. Simple conclusions. PORTEC 4 is an interesting trial because it opened as a trial of VAG brachy versus nothing, and then the VAG brachy had 2 different doses of VAG brachytherapy, and it wasn't doing very well, and the authors went back to the drawing board, rewrote it, and did a randomization based on molecular risk profiling between no further therapy, vaginal brachytherapy, or external beam radiation in kind of this group of patients. I think that's where we're going to go. I think that's where we need to move the field. So if they got low or low intermediate risk patients, they watch them. If they got higher intermediate risk patients, they get vaginal brachytherapy, or high risk patients get external beam radiation. I think that's how we should be thinking about this. This is not one group of patients. And hopefully when this trial comes in, we'll have more prospective data on molecular-driven treatments. And this is from a publication we did a few years ago about what you should do for patients. So what do I do for a patient? Is I get the patient, I try to estimate the risk of recurrence. So in non-invasive, and I try to think of it as what the invasion is, the grade is, and the other risk factors, age, LVSI, and/or large tumor size, and kind of group them in our heads. So for non-invasive grade 1 or 2 patients with no high-risk features, if you look at the data, you compile them, the risk of a recurrence of vaginal cuff is about 0 to 2%, and it's reduced about 50% with radiation. Probably very reasonable to observe these patients. Even the patients with so-called high-risk features that have non-invasive grade 1 or 2, probably very reasonable to observe these patients, fairly similar outcomes. When you get to less than 1/2 myometrial invasion, greater 1 or 2, I consider that low intermediate risk. If you have none of the other risk factors, age, LVSI, large tumor size, that risk of vaginal cuff recurrence is about 3 to 4%. You reduce it to 0 to 2%. I think it's reasonable to either watch those or at least talk about them. I don't want the gynecologists ever making a decision on this. So my rule with them is they send me all the patients that have invasive disease. As I get busier, maybe I'm going to change that rule a little bit, but I got a partner that I can have see the patient who actually wrote this article. Less than 1/2 myometrial invasion or non-invasive grade 3, the risk of vaginal cuff recurrence goes up to about 5 to 6%. Maybe more, I think those patients should be referred to at least have a discussion on risk and benefits of treatment. If you get even higher, greater than 1/2 myometrial invasion or grade 3, the risk of recurrence is probably 8 to 10%. They probably deserve vaginal brachytherapy from a risk-benefit ratio. And then if you get the high intermediate risk group, their risk is even higher. I would give vaginal brachy, but I also consider an external beam radiation depending on the exact patient characteristics. So I do think that this is fairly complicated, and I think you have to kind of try to come up with what you think the risk is, and then you talk about the risk and benefits. And these are just showing the slides. What's the cost of vaginal brachytherapy? If you look at our paper and some other papers, we talk about an acute toxicity of grade 1 or 2 gastrointestinal, 12%, but I'm not sure that's real. I have a lot of patients that tell me they had diarrhea the day they got their vaginal brachy. I think it's just because they were nervous, but they get coded that way. But if you look at late toxicity, it is very low in almost every series. GI, vaginal atrophy are probably less than 1 or 2%, or GI less than 1%, GU probably less than 1%. Depending on the fractionation you do for the vaginal brachytherapy, that's probably the only real long-term risk. And second malignancies, I'll talk about that, although that risk is extremely small. So I think that there's some good data that you reduce the risk of recurrence. How much you have to reduce it per patient, that's up to you and the patient. And this is an interesting article that I quote all the time. It's a treatment preferences and involvement in treatment decision-making of patients with endometrial cancer and clinicians. And it's kind of a busy slide, but what it did was it looked at the cumulative proportion of participants preferring vaginal brachytherapy over waiting, depending on who you're asking. So if you look at the patients who were radiated, they liked virtually no benefit. They wanted the radiation. 80% of them said, I'll get it even if I think the risk of recurrence is 0, which doesn't make a lot of sense. If you look at other people, these curves continually go to the right. So gynocs wanted the most benefit before they would treat people. The patients wanted the least benefit. So I think this is a patient-physician discussion. Societally, that's a different story. Should we be paying all this money to prevent 2 or 3 recurrences? I don't know. But from a patient perspective, I think we just present the data and bring the patient in with a patient decision-making. I don't think it's right to say we should tell patients what to do. So this is, again, the joint decision of how to make these decisions, I think, is very important. So I don't like when our gyne colleagues say they don't need radiation. There's a risk and a benefit to anything we treat. I can decide that, so just let me talk to them. Population-based data. Now, this is also something that only helps if it helps your point, so you only present things that help your point. This is a study we did looking at 132,000 patients from the NCDB database from 04 to 13. The risk groups were poor TEC2 defined, and it was adjuvant radiation versus no adjuvant radiation. And interestingly enough, we published it because it improved survival with any form of radiotherapy for both high intermediate risk and high risk groups. Again, take this with a grain of salt. It's only good if it supports your point. This is a frequency and effect of adjuvant radiation therapy among women with stage 1 endometrial cancer. This was a 22,000 SEER database published by Dave's group in Utah, and it also showed some survival advantage to the addition of radiation in both stage 1C and 1C grade 1 and 1C grade 3. Again, take it with a grain of salt. There is some population-based data, though, that supports the radiation also. This is an interesting study that the group from Duke put out. This was also a SEER database study of 54,000 patients showing improved survival with either vaginal brachytherapy or external beam radiation for intermediate and high-risk patients regardless of lymph node dissection. And in high-risk patients, external beam radiation had improved survival compared to vaginal brachytherapy in patients not undergoing lymph node dissection. All this makes sense. It's all the initial data. So I think that these are strong supporting that patients with early-stage endometrial cancer should be really discussed and thought of a lot whether they need radiation or not. And again, population-based studies support an overall survival benefit for high intermediate risk and high-risk patients with external beam radiation or vaginal brachytherapy. So I think that the story that we shouldn't be treating is not a great story. I think we need to be discussing it, and again, there's a fair amount of data. What about cervical stromal involvement? Remember that stage 2 disease no longer includes cervical glandular involvement. It's most commonly microscopic, which is not visible at the time of exam, and macroscopic is when you can see it at the time of exam. There's some, what should we be doing with these patients? The knee-jerk reaction is everyone gets radiation because there's a fairly high risk of lymph node involvement, but if they have lymph node dissection, do we have to give everyone radiation? So this is 71 patients, 20 of which got vaginal brachytherapy. and they seem to be okay if you pick them well. Another one about just giving vaginal brachytherapy, there was no difference, again, if you pick them well. And another study talking about that also. I'm just going to get to our study, because anything we do is probably better. No, just kidding. So I asked Matt to kind of look at this, and he looked at a multi-institutional analysis of vaginal brachytherapy without external beam for selected stage 2 patients. Do we have to give external beam for everyone? It was FIGO 1988 stage 2B or FIGO 2009 stage 2. Included all histology, endometrioid, serous, clear cell carcinosarcoma, surgically treated with total or radical hysterectomy, no negative. So we looked at, didn't need a lymph node dissection, but most patients did. And it was just the patients that got vaginal brachytherapy delivered without external beam radiation. Plus minus, some patients got chemotherapy. 130 patients were de-identified and the database was created, and the endpoints were patterns of failure, progression-free survival, or overall survival. And this was published last year in Anthony's journal. Again, brachytherapy, 106 total patients. Median follow-up was about 39 months. 98% had a total hysterectomy, 2% had a radical hysterectomy. Most of the patients had pelvic lymph node involvement. 98% had microscopic cervical stromal involvement. So patients were being treated who only had microscopic disease. Again, this is just a retrospective review of who was treated. Tumor grade was mostly grade 2. Grade 1 and 2, there was only about 11% that were grade 3. And then chemotherapy was given more frequently in the higher grade patients. And I'm going to skip this to get to the end point. So the vaginal progression-free survival was pretty good in a selected group of patients, about 97%, both 3 and 5 years. Nodal progression-free survival was good. Distant was a little bit less. And this was a progression-free and overall survival. But what our conclusions are is vaginal brachytherapy alone for stage 2 disease might be reasonable with microscopic cervical stromal invasion, grade 1 or 2, with lymph node dissection and fewer or no other risk factors. So in a very selected patients, this might be reasonable. The 5-year pelvic and vaginal pelvic failure rates in those group of patients were 2.6 and 4.2% respectively. And there's very limited data on the depth of cervical stromal invasion to draw conclusions. So what I'm saying is for stage 2 disease, I think the knee-jerk thing is that we give pelvic radiation, but in very selected group of patients with these risk factors, it may be reasonable to give vaginal brachytherapy. So I do have discussions because of the increased toxicity of external beam radiation. But again, I've never had any toxicity, so that's a little different. I'm just going to touch on sentinel lymph nodes. I think most centers have gone to doing sentinel lymph nodes in endometrial cancer. There are some results that this is a comparison of sentinel lymph nodes to lymphadenectomy. And basically the results were the sensitivity was 97.2% and the negative predictive failure was 99.6%. So if it's done in good hands, sentinel lymph nodes for endometrial cancer is probably a reasonable thing. I have a little concern about done in good hands. I think we did a really good job in the breast sentinel lymph nodes of validating people knew how to do it. I'm kind of seeing people do it because they looked at a video and then they went and did it. So I'm a little concerned about these data are from people that know how to do it, so it makes me a tiny bit concerned that you can put this to the general community. So sometimes I make sure I read the operative report that it seemed like they got the sentinel lymph node. So at times I have given pelvic radiation because I didn't think they got the sentinel lymph node. And I used the other risk factors, so I thought of them as non-lymph node dissections. And this is, again, another talk about whether or not you can only do unilateral, but I think that's not for this group. But suffice it to say, when you're seeing your patients in tumor boards, I think you'll see more and more patients who have had sentinel lymph nodes only for endometrial cancer. And I think you have to be cognizant of whether it was a good sentinel lymph node. I don't know if that's a very definable thing, but at least read the op note and make sure they found one. Because if they didn't find one, they should do a lymph node dissection if they're trying to stage the lymph nodes. Otherwise, consider them non-staged when you're thinking about your algorithm. So recently reported clinical trials, we should just have Mark talk about 249 since he was the lead author. 249 is recently reported at ASTRO, and again, it was stage 1 high intermediate risk group based on the GOG 33 criteria. Age greater than 18 with 3 risk factors, age greater than 50 with 2, age greater than 70 with 1. With the one exception, the depth of invasion was switched from the outer 33% to the outer 50%. And I wasn't in favor of that, but that's a whole other story, and I won't talk about that. Stage 2 patients or stage 1 or 2 serous or clear cell carcinoma lymph node dissection was not required, but most patients did get that. And the randomization was The pelvic radiation arm, which was considered the standard arm for these patients, which I still think it is, was median dose of 45 gray. Was one of the first trials that was allowing IMRT. They used our Atlas. About 36% of the patients got IMRT. BrachyBoost was added in stage 2, or any serous or clear cell histology. 91% eligible patients completed the therapy. And then the other arm was vaginal brachytherapy with chemotherapy. All sorts of different fractionation patterns because we can't come to a reasonable idea what the right fractionation is. And then chemotherapy was started 0 to 3 weeks from the start of brachytherapy. And it was paclitaxel, carboplatin, repeated every 21 days for 3 cycles. So it was a randomization between pelvic radiation or vag cuff and chemo for a high or intermediate risk group of patients. And the primary objective was to determine if vag cuff and brachy reduces the rate of recurrence or death compared to the standard, which is pelvic radiation for this group of patients, and then the secondary effects. The grade 3 or higher adverse events were probably not surprisingly in the chemotherapy arm was 64% versus the pelvic radiation arm was 11%. There was 1 acute grade 5 adverse effect in the chemotherapy arm, although it was related to disease progression, not treatment in the study. This is late toxicity. They were comparable, about 13 and 12%. Grade 3 GI adverse toxicity was 2 versus 1 in the pelvic versus vag cuff. I think with modern radiotherapy, the pelvic toxicity is a little bit less for those that get toxicity. This is the results, and I'm not a statistician, but they look pretty similar, and the overall survival was pretty similar. 36-month relapse-free survival was 82% for both arms. The 36-month overall survival was about 90% for both arms. The estimated rate of vaginal distant recurrences were 2.5 and 18% at 5 years, not different between the 2 arms. The vaginal brachytherapy and chemotherapy had greater toxicity. The pelvic and periodic nodal were more common in the vaginal brachytherapy arm. No significant treatment heterogeneity. Variables studied include stage, histology, performance status, and lymph node dissection. And this is the cumulative incidence of pelvic or periodic recurrences, which were higher in the vaginal brachytherapy arm. So the conclusion of the study is acute toxicity was significantly greater in the vaginal chemotherapy arm. Analysis pattern showed significantly lower nodal failure rate in the pelvic radiation arm. Distant failure rate is a predominant failure pattern in the population, which was about 18% in both arms. And pelvic radiotherapy, I completely wholeheartedly agree, remains an appropriate and probably preferable treatment for this group of patients. And better treatment strategies are needed to address the systemic disease recurrence. The one criticism I've seen people say about this is they only gave 3 cycles of chemotherapy. So I do think some gynecologists say if we would have given 4 to 6, that might have made a difference. But I think for now, pelvic radiation remains a standard. There are some additional resources. We did a ABS survey of practice of patterns for vaginal brachytherapy for postoperative endometrial cancer. We compared it with a survey we did about 10 years ago because, again, everyone does vaginal brachytherapy differently. What was the difference between our previous survey? Almost everyone's using high HDR now. And there's a big heterogeneity between dose fractionation regimes for both monotherapy and boost. Everyone does it differently. I give 5.5 grade times 4 to a half centimeter, the upper 3 centimeters of the vagina for lower risk patients. For clear cell or papillary or clear cell or serous, I tend to give 5 centimeters. Why? Because I got to figure out something. That's what I did. We actually had a randomized trial looking at fractionation patterns that didn't go through the NCI. Dave Gaffney and I are doing a trial now called the SAVE trial, which is your standard vaginal brachytherapy versus 2 fractions to see if we can reduce it to 2 fractions of radiation to save people some having to come in. There's also an ASTRO executive summary of the role of postoperative radiation for endometrial cancer. And it basically says what we said. I think it's a it's a pretty good publication. It might provide some guidance. And we did a guidelines for giving adjuvant vaginal brachytherapy after hysterectomy. Again, I think the only thing, the take-home lessons from the guidelines of how to give vaginal brachytherapy, one of the biggest take-homes that's changed over the years is the increased use of robotic hysterectomy. So with robotic hysterectomy, the vag cuff doesn't heal quite as well. So I think that's something that's different. We have to make sure we do that. Put the biggest cylinder in that fits comfortably. I simply use a single channel cylinder. I think multi-channel probably not necessary. And that's what I would tell you that's what I do. Upper 3 for low risk, upper 5 for higher risk, but that's just what I do. I don't think there's a right answer. There's actually another ABS task force that was published a couple years ago in brachytherapy. There is an upcoming contouring guideline coming soon. It's been 4 years in the making. Trying to get 25 people to agree on a contouring guideline is kind of like trying to get herd cats. It's been unbelievably difficult, but I'm trying to make sure everyone signs off. We had a contouring guideline that we published in 2008. We are updating it for a better definition of the obturator nodes, taking away all bony landmarks in it, because we still have some bony landmarks in the last contouring guidelines. We added the periortic region. We've talked about sentinel lymph nodes, but hopefully we'll be publishing it soon, because I presented it almost 5 years ago. And some people in the room is in here, and I appreciate your comments on it. I'm trying as hard as I can to make everyone happy, which is not easy. So to summarize, I think vaginal brachytherapy decreases the risk of recurrence and is generally well tolerated. Vaginal brachytherapy should be presented as, for these early stage patients, a risk benefit and jointly decided by the patient and the radiation oncologist. That I don't think if you can talk about whether you have time to see all these patients, that's a whole other subject, but I don't think this is a decision that we leave to the gynae oncologist, except maybe for non-invasive grade 1 or 2. I strongly believe that, because this is a nuanced discussion. One of the things I didn't put in here, so what are the downsides of vaginal brachytherapy? We talked about vaginal atrophy, so to speak. That's why I do 4 fractions, why I got away from 3 fractions. I thought I saw more vaginal atrophy, because at 3 fractions at 7th grade or 1/2 centimeters, 10 to 12th grade at the surface, it's kind of a high fraction size. So I cut back a little bit. I think I've seen less. We did a randomized dilator study. I do give patients dilators. I don't know if they help or if it matters much, but I give patients dilators even after vaginal brachytherapy. At least I ask patients to use them. The other risks I talk to patients about is second malignancies. If you look at Dave Gaffney also published a SEER database on second malignancies. If you don't give external beam and vaginal cuff, there's almost no difference. In PORTEC, they didn't see any difference in second malignancies, but I am acutely aware of them. I have found in my practice 2 or 3 vaginal cancers in patients I gave external beam and vag cuff 10 to 15 years before. So I actually start doing pap smears again after 10 years. Just my own, because I've seen it a couple times when you give a really high dose of the vaginal cuff. I also make patients I request patients to get colon screening 5 years after I treat them, and then every 5 years. But that's, again, not evidence-based, just my own thought. Obviously, we didn't talk about it, but we do genetic testing for a microsatellite instability in every endometrial patient. So if they have risk factors, I refer them. I do refer patients who have a strong family history to genetics anyways, because that's just a screen. So I think thinking about genetics when it comes to other screening. And the other thing, the other pearl I've seen this before is someone comes and says they had some blood in their urine, especially if you gave combined therapy. I've seen a few bladder cancers. Even if we think it's from a UTI, I make them go to the urologist and get a cystoscopy. So it's just kind of tweaks. And that's one of the reasons I still follow patients long term, is mostly because other providers aren't thinking of these kind of things. So I think vaginal brachytherapy alone can be considered for patients with microscopic cervical stromal involvement, with grade 1 or 2 disease, with lymph node dissection, and few, if any, risk factors, but that's a really nuanced discussion. Sentinel lymph node, I think, is increasing with high specificity and negative predictive value, so I think that most patients in the future will get sentinel lymph nodes if they get any staging for their endometrial cancer. I didn't put this, I think I put this in one of the other talks. We'll talk a little bit about time C, which is IMRT versus 3D conformal. I think IMRT certainly reduces GI and GU toxicity and improve patient-reported outcomes. So this is much different nowadays than what we used to treat 10 to 15 years ago with using IMRT. I think the toxicity is much less. So the risk-benefit of pelvic radiation is improved by the way we treat nowadays. And we certainly need further molecular stratification of disease, MSI, POL mutations, et cetera, to guide treatment, especially systemic treatment. So I think in the future, we'll stop doing these crude things of grade and stage and depth of invasion and start using molecularly targeted treatments. Pretty much at time. Any questions?
In stage 1 patients and patients who are surgically staged, are there any that you just do external beam alone and not follow it with vaginal cuff?
For the relatively high risk, I would consider it. So a deeply invasive grade 3, even with surgical staging, I often will still give pelvic radiation.
And omit the vaginal cuff?
For the boost, I purposely didn't talk about that because I don't do what I do. I write, not what I say. I tend to give it, but that's me. I tend to give 45 gray and a vag cuff boost, but the data doesn't support it except maybe in stage 2 disease, so I think the right answer is external beam radiation alone is just fine. I get a little nervous if I'm stopping the pelvic dose at 45 gray. So if I'm not going to give a vag cuff, I tend to try to get at least 50, but there's not a lot of data. And if you look at the ASTRO executive summary, we say not to give it because the evidence does not support it. So don't do what I do, do what I say.
Okay.
If you do an MRT, you can also do a simultaneous
Yep.
integrated boost and just give 54 or something to the cuff and give 45 to the pelvis and just do away with the cuff boost. But Bill, I wanted to ask you a question about lymph node dissection. It's often presented in the papers that you quoted and as a yes or no variable. But as you know, that's a continuous variable. For
Right.
example, in GOG 99, where a lymph node dissection was required, one lymph node removed constituted lymph node dissection. So how do you approach that from a decision-making perspective?
You know, I try to keep it relatively simple. So I will say, I only call lymph node dissection, I think, if it's an adequate lymph node dissection. So what do I mean by adequate? Who knows? 10 lymph nodes, I'd like to see if they're doing a real dissection. I like to look at the operative report to see where they opened. You know, they do both sides. Did it look like they got a good tissue? Make sure it's differentiated between the left and the right. I've seen some patients where they got 10 lymph nodes, but they were all from the left, and they got nothing from the right. So I think that's a very good point. So both sentinel lymph node and lymph node dissection, you got to ascertain whether it was a good lymph node dissection. And the crude estimates are whether Memorial talked about making sure in the op node they talked about each station, which I think is great, but you'll never get that in a typical op node. I just make sure they did both sides and that there was at least 10 total, at least 3 or 4 from each side, but I don't know what the right answer to that is.
But if that's not the case, then you have to factor that into
Then
your
it's,
decision.
then it's not a lymph node dissection.
Alex?
Thank you. I've seen a lot of the gynocs starting to say, well, we did a PET CT, and so that counts as checking lymph nodes. Could you comment?
Yeah, that's silly. I would say it's a good point, and I've always thought of this myself. I thought of this in my head, but my head can be a weird place. What's the risk of lymph node metastases in negative imaging? There is a risk. I quote a trial that I think has just been presented. It's in a different tumor site, but I think it's really good. And that's the trial that's being run out of MD Anderson for cervix cancer, where they're randomizing between PET scan staging and retroperitoneal lymph node dissection. And they're finding a 15% false negative rate, where the PET scan was normal and there was still lymph nodes found. So a PET scan to me is not a replacement, or any imaging is not a replacement for lymph node dissection. Doesn't mean those numbers are probably going to be different, because if we say there's a 33% risk of lymph node metastases for high-grade, deeply invasive disease, if you have negative imaging, it's probably not 33%, but it's not insignificant. So I ignore that, to be honest with you. Lymph node dissection is lymph node dissection. Imaging is helpful to look at gross disease. So my algorithm is a patient comes to see me without a lymph node dissection. If they're low risk and probably didn't need a lymph node dissection, I don't image them. They're probably done. But if they should have gotten something or should be staged, I get staging, but it doesn't change my algorithm. I get staging just to see if there's enlarged nodes, where I would either need to boost, do pre-op debulking, treat the periortics, but I don't do it for a treatment decision, if that makes sense.
We ought to go ahead at this point and
Okay.
do the SAM quiz. And just a reminder, all you have to do with these
Do I do that?
clickers is hit the number of the answer that you're
Okay.
choosing and make
Okay.
sure that the green light turns on. You do not have to hit the send button, just hit the answer.
Okay, the first question is the 2009 FIGO endometrial staging system removed which stage? 1A, 1B, 1C, or there were no changes in the staging systems? I hope these are easy, and I wanted to make it as a uterus and a male or female, but I don't like people getting any of these wrong. Yay. Question one is that it's the reason it's important to know when you're looking at like PORTEC2 was the old staging system. It's important to know that it changed. Question 2, GOG 33 established which of the pathological features listed below are associated with positive lymph nodes? Grade, age, depth of myometrial invasion, or did they combine the two? And whoever said 1A before, please get this one right. Yay. 1 and 2. Grade and depth of invasion are important risk factors for lymph node metastases. Okay. Question 3. PORTEC 1 and GOG 99 both noted what approximate improvement in local regional control with the addition of radiotherapy in intermediate risk endometrial cancer? 5%, 10%, 10%, 15%, or 20%? Does a bird need to answer? I hope that wasn't still the 1A person. Yeah. Both studies, again, showed approximate 10% reduction in local regional control with the addition of pelvic radiation. 10% improvement. Again, in PORTEC 1 and GOT 99, what percentage of local regional recurrences were at the vaginal cuff? 75%? 50%, 25, or 10%? I hope that's not the same person just making me irritated. It's probably Jim. It's probably you. Thanks, Jim. I can't do anything more than actually tell you the right answer. So again, this provides rationale for giving vaginal brachytherapy alone. And the final question, and Jim, please don't do this again. The GOG 249 randomized trial of pelvic radiotherapy versus vaginal cuff and chemotherapy in high-risk early-stage endometrial cancer noted which of the following? Chemo with vaginal radiotherapy improved survival. Chemo with vaginal brachytherapy was less toxic. Pelvic RT and chemo vaginal cuff noted similar disease-free and overall survival, or pelvic radiotherapy improved survival. Thanks again, Jim. Pelvic and chemotherapy, they were about the same, and it's important to know those results. Thank you very much.
Thank you. Well, it's a delight to be here today. And I'm going to give a couple of talks this morning and a couple tomorrow morning. If I can get through my talks a little bit more quickly than is scheduled, I may, if you wish, do a little talk of 20 or 30 minutes at the very end of the morning. You won't get any SAM credit for it. But the idea is that we'll discuss either the best or the worst of radiation oncology. So I can discuss the covers of the Red Journal, which is actually a fascinating and kind of inspiring subject, or I can discuss scientific misbehavior, which is something I've unfortunately become very familiar with at the Red Journal. So depending upon whether you want to hear the best or the worst of our specialty, I might add something on at the end of the morning, but we'll see how the time goes. So my first lecture this morning is on prostate cancer. In fact, they're all, three of them are on prostate cancer. This one is on external radiation. And what I want to do is historically run through the evolution of what we now do over the story that runs back about 30 or 40 years. And we're going to begin with discussing how it was and why we obviously had to change. Then we're going to talk about the rise of conformality. Then we're going to discuss what I call the tyranny of dose, which was a kind of trap we got ourselves into for about a decade. Then we'll think a little bit about some existential threats to prostate cancer external beam. And then we're going to talk about the way I think we're going to have to go, should go, and are going. So how it was and why we had to change. Now, many of you have gray hair, or many of you have no hair. And this will be very familiar to those who trained before 1990. This was the way I treated prostate cancer through the 1980s into the 1990s. Everyone had their nodes treated with this gigantic coffin-shaped box that contained nothing but small bowel and bladder. I mean, there wasn't much else in there. In some patients, there may have been some microscopic nodal disease, but the ratio of normal tissue to cancer was thousands to one. This is what we used to do routinely. And then we boost the prostate, and we boosted the prostate in a 2D fashion, usually with a 4-field box, or actually at Mass General it was a 3-field, anterior and two laterals. And if you go and nowadays in our modern conformal era, go and reconstruct what we did and have a look at the dose volume histograms of what we used to do, it is unbelievable that we got away with it. And we didn't really get away with it. We had to limit our doses. We were only giving 64 to 68 gray for prostates. And we were going incredibly slowly at 1.8 gray per fraction, so treatment was running over 7 or 8 weeks. We had to take it slow, and we had to keep it low. And that just was the limitation of the technology. And all the while, we knew that this really wasn't getting the job done. I mean, we were starting to understand from CT scans about prostate motion. You know, this is one man on 3 consecutive days. And you can see the prostate sort of dancing around in there, and the hips moving like chicken wings, and the rectum opening and closing like a politician's mouth. You know, it's all of it. None of that was accounted for in what we used to do. In the 1990s, there was a rise in conformality, and this really came about because not only was CT scanning regularly used in the clinic for diagnostic purposes, we could actually incorporate it into our planning algorithms and think in the third dimension. We just used to think about the central axis. You know, God knows what was going on in the corners of our fields. And there's been a real progressive evolution in technology over the last 20 years. And amazingly enough, much of it is supported by randomized trials. We moved from 2D to 3D, and there was a randomized trial done in Britain on prostate cancer at the Royal Marsden, about 400 patients, half were treated with 3D, half with 2D, and actually there was a lower instance of rectal complications. Boom, we moved up to 3D. going to IMRT, there hasn't been much data in prostate cancer, but there's been data from randomized data from the head and neck world, which I think you can generalize, and from the GYN world. So IMRT became our standard. It was boosted, I might add, by a very generous billing code, but it became our standard overnight in about 1999. And more recently, we're hearing a lot about protons, intensity modulated protons, SBRT, and all this other stuff. And I'll mention that we actually we've almost completed a randomized trial, IMRT versus protons in prostate cancer. And it does also include IMPT. So all of this stuff is going on. I'll say a little bit more about SBRT later. So we're quite an evidence-driven specialty. So dose was a kind of trap we got ourselves into for a decade or so. We, as radiation oncologists, our knee-jerk reaction to, high local failure rates is more dose, more dose, more dose. And we did a whole series of dose escalation trials through the 1990s. They were reported in the first decade of this millennium. And they all showed the same thing. You could actually reduce the level of PSA failure, but none of them demonstrated an improvement in overall survival. The MD Anderson trial hinted that there was a decline in the 10-year instance of distant metastases in those with high-risk disease, but really, dose didn't seem to be the total answer. Or there wasn't at least as much benefit as we'd hoped. These trials, which used a mixture of IMRT and 3D, also very carefully measured the toxicities, mostly physician-reported, but more recently a lot of patient-reported outcomes. And usually with dose escalation, even with these conformal therapies, there was a rise in rectal morbidity. There was usually a stable or a rise in GU morbidity, and there's no difference in terms of erectile function. So dose seemed to be improving surrogate endpoints, but not necessarily the real endpoints. And if I'm talking about high technology, I can't, in the world of prostate cancer, you can't move on without at least saying something about proton beam. And I've been sort of fairly vocal on this subject over the last decade. And I think we're for those of us who treat prostate cancer, if we got a penny for every patient who came to us and plopped a Bragg Peak down in front of us that they downloaded from the internet and told us this is the way they want to be treated, we'd all be very rich men and women. But because of the explosion in number of proton centers around the United States, there are well over 20 now, we'll probably top out at around 40 is my guess. And because still half the patients in the United States treated with protons are prostate cancer patients, we can't not discuss this subject. So my concerns about proton beam are not that it's a poor treatment. I think it's actually a very good treatment for prostate cancer. But that we made a lot of assumptions about proton beam in the early 2000s that aren't quite panning out. It's more complicated than we think. It turns out there were a lot of physical uncertainties in the treatment of proton beam. When we treat prostates with protons, we have to use opposed lateral fields. And that's because there's some end-of-range uncertainty. So if you use anterior beams, if you're going to account for the end-of-range uncertainty, you have to overshoot. So what do you overshoot into? The rectum. So we use opposed lateral beams. And, it turns out there's a penumbra on the proton beam. And it's bigger the deeper you get. And there is nothing quite as deep as a prostate in an American male's pelvis, especially when you're coming in from the sides. So there is a penumbra. It's actually worse than 18 MV photons. And protons are very sensitive to dose inhomogeneities. So the position of the hips from day to day determine whether you're going through soft tissue or bone. And that can alter the shape of the beam. And actually, if you do daily dosimetry, you can, you don't have a beautifully conformal field. You have something that looks a little bit more like an amoeba, which is actually what you've distributed. So there were these physical uncertainties that we weren't appreciative of until relatively recently. And there are also some biological uncertainties which we had completely dismissed, but are now absolutely central to our thinking. We've made assumptions about the RBE of proton beam. We thought, the RBE is approximated at 1.1. That's how you prescribe your dose. But it turns out it changes with LET. It changes across the spread out Bragg peak. It's highest just beyond the Bragg peak. Another reason we didn't use anterior beams, because it would be highest right in the rectum. It changes with fraction size. And with the move towards hypofractionation, how does this play out? I don't know. And it changes with the alpha-beta ratio of the tissue. So there are all these uncertainties. Now, we used to think, well, maybe all this stuff doesn't matter, but it does. And it's starting to become clear in pediatric cancer that there are, if you account for these things in planning, say, of a brainstem tumor, you can actually account for some of the unanticipated morbidities that have been seen in the pediatric brainstem. Now, you can use these as these issues can be your foe, or if you can dump all these negative consequences right into the middle of the tumor, you can make them your friend as well. But you have to adjust for this kind of thing. And this is we're just in the early stage of understanding about this. It's very important. But does proton beam cure prostate cancer? Absolutely it does. The University of Florida have a very nice sort of longitudinal series, high rates of biochemical disease-free control. Does it cure more patients than brachytherapy, which of course LDR brachy is the low-cost, big bargain alternative. And we've done case-matched analyses of patients from our randomized trials and patients we treated with brachytherapy across the same era. We couldn't find that protons cured more patients than brachy. So we wondered, does it reduce morbidity? And the University of Florida have these lovely grade 1, 2, and 3 curves. Really looks very, very good in terms of rectal and GU morbidity. We actually looked at this a little bit more deeply using 2 contemporaneous prospective cohorts in which we use validated quality of life surveys. And you really don't need to look at the data. But just note that almost all the values, these are patients treated with well, in this column marked PROG 9509, those are proton-treated patients, and the Boston survey are 3D and IMRT-treated patients. And the numbers, very good. And the numbers are pretty similar if you look right across the columns. So when we asked the patients, and we had long follow-up, we couldn't find a difference between our proton-treated patients and our 3D and IMRT-treated patients. And then some data started to emerge that was a little troublesome. Does proton beam increase morbidity? Now, I'm not going to argue that it does, but there was one population-based SEER study that seemed to suggest that protons increased the rate of subsequent GI diagnoses, probably rectal bleeding, which might feed in with the fact that we really didn't understand the penumbra and we really didn't understand the RBE of proton beam. So the physics sometimes looks better, but could the biology be worse? The answer is we really don't know. Luckily, there is a randomized trial going on. So we're 330 patients into a 400-patient randomized trial, which will complete this year, comparing IMRT to protons in prostate cancer with quality of life endpoints. So we will have the answer in 2021. I have complete equipoise on this one. Protons could be better. They could be just the same, or they could be worse. It's going to be fascinating to find out. And this is one of the most watched randomized trials in medicine. We frequently get calls from the Wall Street Journal and the New York Times and the LA Times. Your trial done yet? Endlessly. They're very interested in proton beam as an emerging and very expensive technology. And the new craze in external beam, of course, is spot scanned proton beam or intensity modulated proton beam. And this is where you, instead of what you do is you use tiny little spots of radiation, and you essentially paint them from the back of the tumor forwards. It's a very nice technology. It gives you incredibly conformal fields. It allows us now to use anterior beams and not treat right through the hips. So, do I think that will be a step up? It probably will. But like everything, I really think these things have to be tested, and ideally tested in a randomized fashion. So, the desire to deliver incredibly high radiation doses was part of the drive behind the development of proton beam over the last 2 decades. Another thing that's become very popular is the notion of increasing your biologic dose by adding, boosting your external radiation with some brachytherapy. And this is something I've done a lot. It sort of seems like a logical thing to do. It's a nice conformal boost. And the Canadians, actually a group in Vancouver, completed this randomized trial called ASCEND-RT. And basically, they took guys with intermediate or high-risk cancer, gave them some hormone therapy. Half of them had conventional dose-escalated external beam to, I think it was 76 or 78 Gray, and the others had a mixture of external beam and LDR brachy. And they have good follow-up on their patients. Actually, the median follow-up is now over 7 years. And they did seem to show an improvement in progression-free survival. And you think, boy, I could drive, a London double-decker bus between those 2 lines. This is what I should be doing for everyone. And that's my first instinct. But I have to say, out at 10 years, there's absolutely no difference in overall survival. No significant difference in metastasis-free survival. And most disturbingly, quite a high level of urinary toxicity. And it's actually a 4-fold increase in overall urinary toxicity by using the combination of external beam and brachytherapy. And actually, troubling is that there's a particularly high risk of late urethral stricture. And those urethral strictures have to be managed by dilatation. Dilatation, the more often it's done, the more likely it is that the man becomes incontinent, or the strictures become so tight the men have to catheterize or require suprapubic tubes. So this is the price of very high dose escalation. So this isn't my first choice. I use this for some younger men who refuse to have hormone therapy, but I think they've got high-risk disease and they need some dose escalation. But they have to accept that there may be a long-term price, a decade or more down the line. Now, another thing that's become of great interest is we all know from looking at MRs these days that there's usually a dominant lesion. When the prostate comes out, the prostatectomy, there's the dominant lesion, there are little lesions. But the assumption is that the little lesions you get rid of with your regular radiation, and the dominant lesion is going to be the site of local failure. And actually, local failures are often unifocal and often at the site of that dominant lesion. So logically, you might think that boosting that dominant lesion makes sense. This is called the index lesion. And there are many reports associating the index lesion size with tumor control after radiation. And it is now possible. You can do it with brachy. You can do it with proton beam. You can do it with IMRT. It really doesn't matter. You can do it. And many folk on clinical trials are giving 90 Gray or thereabouts to dominant nodules. But I don't think this should be our everyday practice. I really, really don't. 90 Gray is 90 Gray. Our treatment is only so accurate. And don't worry, the British and the Germans are doing randomized trials of exactly this kind of therapy at the moment. So we will have the answers. And at the same time as there was this move to give higher and higher doses, there was a movement in the opposite direction. What about 0 Gray? Well, this is a trial I've been very involved in over the last 20 years. I've been on the steering committee. This is the British PROTECT trial. And it's the most It's just the most amazing randomized trial I've ever had the honor to participate in. They took 500,000 men and they randomized them by family practice into either PSA screening or no screening. That's called the CAP trial. And that trial is recently reported in JAMA negative. No advantage to PSA screening. But put that aside, that's not the subject of today's discussion. Of those who were PSA screened, there were several 3,000 cases were detected. And those men were offered randomization, and 60% of them accepted randomization into either surgery, external beam radiation, it happened to be with a little bit of hormone therapy, or what they called active monitoring. I mean, just an amazing randomization. And once patients were randomized, they didn't skip. It's not like they were randomized to radiation and say, oh no, I really want surgery. No. If there was any skipping anyway, they were skipping towards active monitoring. And the 10-year results that were published in the New England Journal a couple of years ago were extraordinary. These were intermediate and low risk prostate cancer, 75% low risk, 25% intermediate risk. This was the prostate cancer mortality. Less than 1% for all 3 arms. I mean, it's remarkable. And then what about clinical progression? So the lower curve, the green curve, is active monitoring, and you were more likely to progress clinically. About 7% of those progressions were metastases. The remainder were local progression, T1 or T2 to T3. Not necessarily symptomatic, not necessarily life-threatening, but it was definitely progression. And if you had radiation or surgery, you were less likely to progress, and you were equally less likely to progress. So what do we all conclude from this trial? Is treatment better than surveillance? Well, in some ways, yes. It does reduce your progression at 10 years. And maybe in the second decade, that will translate into some kind of survival advantage. Just hasn't yet. The 15-year data is going to be reported next year, by the way. So we'll get that answer. Is surgery better than radiation? Not in terms of disease control, and certainly not in terms of morbidity. This surgery did not look good in this trial. So this was a boost for external beam radiation on the one hand, but it reminded us that we were massively over-treating patients on the other. And 0 gray is probably as good as 79 gray for a whole lot of men. So there are a lot of existential threats. These haven't been easy days for external beams. There's the rise of active surveillance, and also there was the rise of the robot. And the robot was about the only thing that was that sort of captured the imagination as much as proton beam. And as you can see, external beam has taken a decline over the last decade, particularly for low-risk patients, and actually appropriately for low-risk patients. Active surveillance is appropriately on the rise. So one of the problems for external radiation at any, whether low risk, intermediate risk, or high risk disease, is that it's become incredibly lengthy treatment. You're talking about 8 or 9 weeks of treatment. And you're trying to sell this to a patient who's got the option of, a one-night stay in hospital, having had a prostatectomy, a catheter for 1 week. By the time they're finishing their external beam, they're long over their radical prostatectomy. External beam was starting to look uncompetitive to surgery. So there has been a big move towards shortening up external beam radiation. This is what I really want to discuss. Contracting radiation, using our advanced technologies that treat tighter volumes and much less normal tissue to accelerate treatment by using hypofractionation. So this is all, it doesn't really matter what your delivery system is, protons or VMAT or whatever. You can, these are big things that I think do make a little difference. There are certain little things that I believe make a big difference, and that's just simply using daily imaging and some fiducial markers of some kind. Cone beam is now fairly routine around the nation. And actually, there is a Dutch trial, the HYPRO trial, which is a trial of hypofractionation that I won't discuss. But in a secondary analysis, they looked at those patients who have been either MR planned or planned with endorectal balloons. And actually the morbidity of patients who'd have this, just these little extra things, was significantly lower than those who've been planned without the endorectal balloons. And it's just a sort of validation that these little things may make the bigger difference. Another thing that's very popular at the moment are these colloid gel spacers. And there actually is randomized data to support the use of them. I mean, it's a slightly soft randomized trial, but it does show, and you would expect this. If you can inject some colloid gel between the rectum and the prostate, create a 1 centimeter space, you would expect that there is going to be lower rectal morbidity. And so it seems to prove. It's not a huge difference, and I think that reflects the fact that it's hard to get this colloid in exactly the right place. Sometimes it's off to one side, off to another side, it's too high, it's too low. And of course it doesn't alter the GU morbidity at all. Why should it? Your bladder neck and your urethra is fully radiated. And actually, the rectal morbidity is probably the least problematic morbidity that our patients face. If you look at patients who've had high-dose external radiation, you follow them 10, 15, 20 years. By 15 years, 50% of them have had an episode of hematuria. That often puts them in hospital or requires investigation, cystoscopies, hematuria protocols, CT scans. That's our dirty little secret, that we have these very high and ever-increasing levels of GU morbidity. The GYN folk have known that for a very long time, but we in the prostate world haven't acknowledged it. And if, so you don't have an MR in your department, you can't, it's not easy to see this colloid gel just with CT scan. Well, if you don't have that, you can actually aerate the gel, you can make it bubble up, and then you can very easily see it on CT scan. Or you could just use something simple like venous blood. This is what I do on my brachy patients. Do brachy, and then at the end of the procedure, I'll inject blood. I'll ask the anesthesiologist for 10 cc's of venous blood. Just it clots, and you've got a nice little spacer that will last you, until it's absorbed. Several weeks, certainly. So with these advanced technologies and little embellishments, we can shorten up radiation. And the appeal of hypofractionation is that it's more convenient for the patient. You say to a patient, you've got 9 weeks of treatment, the shoulders go down. But if you say it's only 3 or 4 weeks, it's not such a big deal. It's much more convenient for our department. We have wait lists for prostate treatment. Wait lists, 6 weeks. We can cut those down. And it reduces healthcare costs and patient wait times. So it's all good, and I might add, I didn't put it here, it makes radiation more attractive as an option for patients. And the evidence around the hypofractionation is really very deep right now. We've got 4 randomized trials that contain over 6,000 patients. This is the RTOG trial, 0415, reported by Robert Lee a few years ago. It's modest hypofractionation, 8 weeks treatment versus 5.5 weeks treatment, non-inferiority design, and really, in terms of efficacy, there's absolutely nothing in it. There was a slightly higher risk of grade 2+ toxicity, but actually when you ask the patients, there wasn't. Usually doctors underreport morbidity, and it's the patients who let you know. This is, in fact, in this trial, it was actually the opposite. So it seemed like you can shorten up to 5.5 weeks at no cost to the patient. And this is another British trial that I've been very involved in called the CHIP trial. It took 3,000 men. It randomized them 3 ways. The basic randomization was 60 gray and 20 fractions against 74 gray and 37 fractions. But they threw in another fractionation, 57 gray and 19. They threw that in because these alpha beta calculations that we make, they are so imprecise and based upon poor data. So they didn't know that whether 60 and 20 was actually going to be too much. So they put in a third arm that was a little bit lower, just in case. And because in Britain, all the cancer centres in Britain are essentially joining one network, and they take incredible pride in putting patients on randomized trials, they knew they could get this trial done in no time at all. And actually they did. They only planned to have 2,000 patients, but they were done 2 years ahead of schedule and didn't have a successor trial worked out yet. So they threw in another 1,000 patients just to add the power. And actually, with the last 500 patients, they randomized to IGRT versus no IGRT, cone beam versus no cone beam. That data we haven't yet seen. That will be coming out in the next year or so. So in terms of the efficacy, there was no difference. 60 Gray and 20 fractions was not inferior to the 74 Gray and 37. 57 Gray, they couldn't exclude the possibility that it was inferior. This is these non-inferiority design trials. So, but when I look at these curves, and I've got some little old man I'm about to treat. I can give him 60 Gray and 20, but for a little old man, seeing curves that are really so close, I'm happy to give him only 57 Gray and 19 fractions and get him done in 3.5 weeks rather than 4. So I think this kind of increases our range of options, and it does so in an evidence-based way. And in terms of the late toxicity, there was absolutely nothing in it. Nothing at all. I've seen the 8-year data, there's still nothing in it. Nothing. Identical in terms of efficacy, identical in terms of complications. So this actually is my personal standard. This is what I have for the last couple of years. My patients receive 60 in 20. The little old men, I get 57 in 19. And how many of them are little old men? A lot. And then this kind of raises another question, doesn't it? Well, if we've gone from 8 to 5.5 to 4, just how low can we go? Well, this is a very intriguing Swedish trial by Anders Widmark, only published as an ESTRO abstract so far, so no one's seen the paper. Over 1,000 patients, intermediate and high risk, and they were randomized to either 78 Gray, 8 weeks treatment, or 42.7 Gray at 6.1 Gray per fraction, just a couple of fractions per week, over a couple of, or 3 fractions per week over 2 weeks. I mean, this is, these are SBRT doses, except they weren't using SBRT, they were using 3D and IMRT. That's how they were delivering the treatment. And no image guidance, I might add, until more recently. None of the patients had androgen deprivation therapy, which is a little bit funky. With a median follow-up of 5 months, efficacy was non-inferior, so that at least with these doses, 42 Gray at 6 Gray per fraction, it didn't appear to be inferior. And physician-reported toxicity, there was no difference between the 7 treatment and the 39 treatment fractionation. So far, now none of us have seen the paper, so this is very preliminary. But, maybe it won't be 4 weeks in the future. Maybe it'll be less. Which gets us on to extreme hypofractionation, which is 1 week treatment. Now, you all, most of you probably have SBRT. Many of you will be treating prostates already with SBRT. And the evidence for treating prostates with SBRT is largely single institution reports or some prospective multi-institution reports. I mean, it's data. It's not high-quality data. It's not comparative effectiveness data, but it's data. We certainly know that PSAs come down after SBRT, and in many cases they stay down. We know that morbidity is low. We don't know how much lower or higher it is than other forms of radiation. So once again, you have to thank the British. So we have a randomized trial going on called the PACE trial, taking a whole bunch of patients with low and intermediate risk cancer who are surgical candidates. We've got, it's a 2x2 randomization. There's PACE A and PACE B. PACE B has been incredibly successful. PACE B began as 78 Gray versus a sort of standard SBRT 5 fraction schedule, say 6.25 and 5 fractions. But actually, with the publication of the CHIP trial, and actually when that CHIP trial was published in 2016, Britain moved overnight from 8 weeks to 4 weeks of treatment. Canada has done the same, 8 to 4. That's the evidence, we accept it. So half the patients are treated with 78 Gray in 7.5 weeks, and half are treated with 62 Gray in 20 fractions. So that randomization went very well. That closed about a year ago, 850 patients. The less successful was prostatectomy versus SBRT. We've actually had to close this at only 150 patients because patients wouldn't accept randomization in Britain to surgery. It's not for us. It's not for us. It's for the Americans. We don't do that. But so we are going to have the data. The first data from PACE will come out in 2021 or 2022. And I don't know what that data is going to show. SBRT is like proton beam. It might be better. It might be worse. It might be just the same. We are yet to find out. The problem with extreme hypofractionation is we actually don't know what dose to give. You know, at least with the conventional fractionation, we've inched up the dose over the years. And we've found out what's the safest dose we can possibly give. But here we have no idea. We're dealing with fraction sizes of which we have no personal experience in a part of the body that's not used to fraction sizes this high. You know, the standard is whatever it is, 36.25 in 5 fractions. But others are testing 40 in 5, 45 in 5, 50 in 5, 24 Gray as a single dose. I don't know which of these is right. So if the PACE trial is negative, will it be, is inferior, would it be argued that it's because the dose was too low? I don't know. But there's much to be learnt about SBRT, and I think we're only at the beginning, and we're guessing. So will hypofractionation happen? Well, 4 to 5 week schedule, I think really should. There's a solid evidence base. Canada and Britain have switched. And the 1 week schedules, there's much less of an evidence base. I think moderate hypofractionation faces a bit of an uphill battle. It did with breast cancer, as you all well know. The rates of adoption in breast cancer have been relatively low. And the reason is likely this. The reason is that, the fewer fractions, the lower the reimbursement. It's as simple as that with standard external radiation. Until you get to a point when, once you're down at 5 fractions, you're in a new billing category. So do I think moderate hypofractionation has a chance in the United States? Well, I think it has a chance, which is not a very good one. But SBRT, you betcha. Ahead of the evidence. So what do I think about these extreme 1 week or even 1 day fractionations? I think maybe they're right. I think prostate brachytherapy was adopted without randomized data and has proved to be a very useful and durable treatment for prostate cancer. But maybe they're wrong. PSA screening hasn't turned out to be the miracle we thought. Proton beam, it certainly isn't vastly superior to all the other things we're doing. It might be superior, but if so, only just. And then all the other things in medicine, which we've assumed until the randomized trials come out was superior. Bone marrow transplants in breast cancer, postmenopausal hormone therapy, you name it. So when it comes to shortening up radiotherapy, my conclusions are that we have the technology and we're starting to understand the biology. We have 5 randomized trials that support 4 to 5 week courses as safe and effective. And I think this should happen now, but I acknowledge there are some financial obstacles. And the evidence is still awaited on the 1 week or less courses, but the financial obstacles don't exist. So I'm actually fascinated to see how this is going to develop over the next few years. The trials will come out, we will have evidence, and we'll either have to backpedal or we'll be sort of marching on into the future. So I'm going to stop there. I'm just going to show you one image that this is a patient I saw last week in the clinic, and it was like it was like a deliverance from God. This is a guy with a large median lobe, and when I looked at his MRI, I saw this. It's Valentine's Day. What did that prostate know? So I'm going to posit, I have a new theory of prostatic intelligence. And if only we spoke to the prostate, it would give us the right answers. So with that, I'll stop and let's do I'll take some questions if there are any questions from the audience.
Thanks for the great talk. So do you hypofractionate everyone, low, intermediate, high risk? And
Yes. I treat very few low risk these days.
Okay.
And
then, so the intermediate, high risk, you add the hormonal therapy, but
Yes, I do.
hypofractionate.
I do.
So then who are you doing brachy boosts as per Ascend RT? And
Well, the brachy boosts, I've been doing them on very few people. I've been doing them on younger men who refuse surgery, refuse hormone therapy. You know these guys, on whom I think, standard external beam just ain't enough for you. You with your intermediate or high risk disease. I've got to do something extra. And that's what I've done.
Before the coffin field in the 70s, a lot of people treated prostate only with arcs or
Yeah.
rotation.
Butterfly arcs.
And then the more is better concept came into vogue, and that produced the coffin field.
I take your point, yes.
Questions?
When do you decide to treat pelvic lymph nodes? And if so, how would you incorporate it in a hyperfractionation schedule?
I treat younger men with high-risk disease. It's as simple as that. Older men with high-risk disease, I've no interest in treating their nodes. But younger men with high-risk disease, I will treat. I'll then use the 5-week schedule, because it's easy to use. You use 2.5 Gray on the prostate and 1.8 Gray on the nodes. It's very easy to incorporate. It's trickier with the 60 and 20. Yes.
We've been more inclined now to add a brachy boost for those with Gleason 9 and 10 with the JAMA paper last year.
Yeah.
You have any perspective on that?
Yeah. I mean, I think we've underestimated the Gleason 8 and Gleason 9 cancers. I think there are higher rates of local failure than we previously appreciated. And I guess, if you triple your rate of urinary complications, well, maybe that's acceptable if it reduces the rate considerably of local failure. So I agree. I think it's a reasonable thing to do.
Do you for the 20 Gray, or excuse me, the 60 Gray, are you comfortable doing that without spacer OR or using blood like you did?
Not one of those 3,200 patients had spacer OR. And actually only the last 500 even had fiducial markers.
Gotcha. Thank you.
You have any comments about LDR brachytherapy versus HDR?
I think they both work.
No, I think they both work. As far as the late urinary strictures and complications, because
there are no head-to-head comparisons. They're just institutional series with institutional expertise. I mean, there are risks with both, and they're probably similar.
Thanks for a great talk. I primarily do pediatrics at the Proton Center in San Diego, but I was at Loma Linda at the time that the Sheets group was looking at the toxicity increase from protons there. And I think one thing when I talked to my colleagues there at Loma Linda that was concerning about to us about that was what was used as a surrogate for GI toxicity in that SEER review was colonoscopy usage on Medicare billing data. And when I was at Loma Linda, part of our protocol for all those patients was to get a colonoscopy. And so I think it was artificially inflated, I think I should say, for those patients that were reported as GI toxicity and was part of our protocol to do that colonoscopy.
You may well be right, except I will add, the only rectal fistula and rectal ulcers I've seen in my patients in the last 20 years have all been proton patients. So I think biologically there may be something different. I mean, it's not many, and I don't want to exaggerate that, but it's just what I've seen.
I hate to be the person that calls the emperor naked, but I mean, we've looked at the proton thing, and the best we can come up with is perhaps, that it's equivalent, but it's astronomically more expensive. So why are we still chasing this dragon?
Oh, I hope we won't. I mean, I'm expecting when this randomized trial, if this randomized trial is negative, unless proton beam becomes fantastically less expensive, I think you're going to find insurers are going to push back. In fact, they're pushing back right now for prostate cancer. There are other very good indications for proton beam. It's just that prostate cancer became the economic driver of the proton expansion. I mean, I think it inappropriately, but that's a whole other discussion. But I take your point entirely.
So that's actually kind of where my question was going is prostate cancer, do we need prostate cancer to be viable, or do we need proton therapy to be viable in prostate cancer to be able to support 20 to 40 proton therapy centers in the United States that really do a great job at treating things like pediatric medulloblastoma? Sure. Are those the people who are actually going to suffer if proton therapy is not viable in prostate cancer? Yeah, well, that's the risk, is that we'll end up throwing, you know, if proton centers collapse, then we won't have pediatric options available. So you throw the baby out with the bathwater. But it's equally absurd to have old men with cancers that don't need to be treated at all being treated at great expense in order to subsidize kids. I mean, what's wrong with that kind of healthcare system?
Yeah, excellent, Dr. Zeidman. Do you have any comments on using Axumin scans as staging initial?
Not for initial. I'll talk about Axumin tomorrow.
No other questions?
All right.
Then we can do the SAM quiz.
Now, I write a lot of these questions either for the ABR or for the Red Journal, so this I can do with my eyes shut. And perhaps there'll be some evidence I did it with my eyes shut. So, which of the following clinical scenarios is not supported by randomized data? 3D radiation, moderate hypofractionation, dose escalation, the use of colloid gel spacers, or SBRT? Off you go. Sorry, actually, can we go back and have a look at that distribution? So, yes, SBRT is not yet supported by randomized data in prostate cancer. In prostate, I mean, it is in lung cancer. The use of colloid gels is supported by randomized data. All right, the randomized trial was small and data is weak, but it's supported. And 3D radiation actually is supported by the British randomized trial. All right, next question. Ooh, proton beam. So let's test what you know about proton beam. Proton beam has a variable. So one of these is wrong, I believe. Is that right? So, yes. No, one of these is right. Has a variable and uncertain RBE. Usually employs anterior beams. Is less sensitive to prostate motion than photons. Has shown lower rectal morbidity than prostate brachytherapy, is less sensitive to tissue density than photons. All right, yes, it has a variable and uncertain RBE, and that's the friend or foe concept of proton beam, and that we are hoping to exploit in cancers other than prostate cancer. Number 3, when compared with external beam monotherapy, the combination of LDR brachy and external radiation, one, has the same, this randomized data, has the same rate of biochemical recurrence, has a higher rate of urethral stricture, has a higher rate of distant metastases, offers better penile bulb sparing, offers a lower BED to the prostate. So there you go. It has a higher rate of urethral stricture, and you got that right. The PROTECT trial. Fewer than 200 patients were ultimately randomized. The results were invalidated by patients seeking treatment other than their randomization. External beam caused higher relapse rates than surgery. Prostate cancer deaths were highest with active surveillance. The 10-year risk of prostate cancer death was 1% for all groups. So the take-home message of that trial really was how well and for how long men with low risk and intermediate risk prostate cancer do. And this is why, in my practice, men in their 70s with low risk disease, I rarely treat them unless they have failed active surveillance. And men in their 80s with intermediate risk disease, I rarely treat at all. Moderate hypofractionation has rapidly become the standard of care in the United States. Does not reduce overall healthcare costs because of the catastrophic cost of complications. Is inconvenient for patients because of the need for daily imaging. Has been universally adopted in the UK and Canada, and is associated with high rates of radiation cystitis. Well, there you go. Make of that what you will. All right, that's all from me on external beam for prostate cancer. Thank you very much.
Thank you very much.
Thanks, I'm back. And I must admit, I'm not so happy with Anthony. He's not hearing me, but he's actually was funnier than me, and that really bothers me. I don't like that. I don't have any jokes. You didn't hear me, did you? I'm not really happy about this, but I would like to thank the organizers again, especially Jim. Although one thing, I looked at the official website for this meeting, and that, I think, the picture of me in there is actually, I think, the worst picture I've ever taken. And I don't know if that was just mean because I was only doing 4 talks. I thought 4 talks was a lot, and I wrote the SAM questions too. So I gotta try to work on that. So we're gonna talk. This is kind of a hodgepodge of topics, some of which I touched on last time. But we're gonna talk about medically unresectable and advanced endometrial cancer. Disclosures have not changed in the hour I was sitting watching Anthony's talk. So our learning objectives, this might not take a full hour, but we're gonna review the evidence of adjuvant radiotherapy in the advanced disease setting, discuss risk and benefits of adjuvant radiotherapy. It's gonna become more and more controversial when a certain paper gets published soon. Discuss the management options for recurrence, discuss management options for medically inoperable endometrial cancer, review some evidence of why an IMRT is probably now the standard of care. I'm also gonna show you some interesting contours. Discuss recently reported clinical trials, and discuss RT-induced adverse events, again, that you guys get, I don't. GOG 122, Dr. Randall is here. This is his paper was a great study, a very interesting study. I personally, in my history of treating, I used to give a lot of whole abdominal treatment for advanced endometrial cancer. This study probably stopped me from doing that. So it's a randomized trial, hysterectomy BSO with either periodic nodes negative or unknown periodic node status, or positive periodic nodes with biopsy negative scaling nodes and negative chest CT. So these were advanced patients in this trial, and it was a randomization between whole abdominal radiotherapy and regimen 2 was chemotherapy. So it's RT versus chemotherapy, doxorubicin and cisplatin. So it's interesting that this really did change the standard of care for advanced endometrial cancer, despite the fact that no one gives this chemo. Just an interesting thing. And this is the results of survival by treatment group, showing that the chemotherapy arm did better than the whole abdominal radiation arm with a good p-value. Since Dr. Randall is in the room and he's a friend of mine and invited me here, I'm not going to go over the criticism of this trial. There are certainly some things that people can point to that maybe this was an interesting trial. For instance, it was 45 gray to the pelvis, no necessary boost, any gross residual disease, not necessarily what we would do. I think one thing that is missing, and I think that would be nice to look back at the data, is if you recurred at the vaginal cuff, you could then do anything you wanted to. So in the chemotherapy arm, we talked about 50 to 70% salvage rates for vaginal cuff recurrences. So in the non-radiated arm, there was probably a significant salvage rate that may explain why the arms have separated. So there's some criticism, but what it does show is that there might be an option for adjuvant radiation in endometrial cancer, which we didn't do. For those of you that have gray and no hair, we used to never give chemotherapy adjuvantly for endometrial cancer. In fact, when I tried to get my gyne-onc colleague, to put people on a randomized trial with Taxol, he said, why would I give hair removing chemotherapy that is not needed? So this is, in the past, chemotherapy was just not delivered. But there is some data. There's other data on randomizations for chemotherapy in advanced cancer. And this is Maggie, which was published in the British Journal of Cancer in 2006. You know the Brits, they can get things done fairly quickly. Actually, it wasn't the British, but this was a stage 1C grade 3, stage 2 grade 3, greater than 50% myometrial agent, or grade stage 3 disease. So high-risk patients randomized the radiotherapy versus chemotherapy, pelvic RT, or cisplatin majoromycin Cytoxan for 5 cycles. So a little bit different chemotherapy. And what are the results? With a median follow-up of 95.5 months, not bad median follow-up. There was no difference in 5-year disease-free survival, overall survival. RT local regional initial recurrences were 7%, distant recurrences were 21%. We're gonna come back to those numbers because we're gonna talk about GOG 258, which is what's gonna come out soon. Chemotherapy local regional recurrences were higher at 11%, distant recurrences were lower at 16%. But they balanced each other out. RT reduced local recurrences, chemo reduced distant failure rates, so that they were about the same. So you make the obvious assumptions. Why don't we give both? Wouldn't it make sense to give both? So there was this randomized trial, GOG 34, which was RT alone versus RT plus adriamycin, kind of a harsh treatment. The 3-year survival in the RT alone arm was 75% versus 68% in the RT plus adriamycin arm. So it was actually worse 3-year survival. There was more extra pelvic failures, 22.5 versus 16.3. So this is a theme. You'll see the extra pelvic failure rates are between 20 and 30% in most of these patients. But 7% of these patients had surgically staged, developed small bowel obstruction, so it was very toxic. And maybe adriamycin alone is not the chemotherapy you should give. This, for a long time, Dave Gaffney and I were the co-chairs of the R2G working group for GYN. And this was one of the best trials we did, I think. Certainly not including R2G 9001 for cervix, but this was a very interesting, thought-provoking trial that was done 20 years ago. So this was well ahead of its time. This was Kathy Grevin, who published it in Gynecology in 2006. Stage 1, and this is the basis for PORTEC 3, and I'll get to that. This is stage 1 to 3 patients considered high risk who had hysterectomy with or without nodal staging. It included grade 2 or 3 patients with greater than 1/2 myomutual invasion, or stage 2 patients and extrauterine pelvic only disease. Pelvic RT, 45 gray, plus a vaginal brachytherapy boost with cisplatin, 50 milligrams per meter squared, days 1 and 28. This is a phase 2 trial, and 4 cycles of carbotaxol. So it was combined therapy in advanced disease or high-risk disease. Just what we're suggesting. All the trials suggested that radiation works locally, chemo works distantly. Why don't we combine them? And the results of this trial, there's only 46 patients, was stage 1 or 2 high risk or stage 2, 3 disease was 66% of the patients. 4-year local regional relapse was 4%. Distant was 19%. Again, lower than we've seen on those other trials of 20 to 30%. 4-year disease-free survival and overall survival were very good. Stage 3 was 77 and 72. A lot of people talk about 50 to 60%, so there's a signal that this might be a good thing to do. And there was no recurrences in stage 1C, 2A, or 2B. Now, this is a simple, small phase 2 study, which led to a randomized study, R2G 9901. That means it was started in 1999, which, if my math is correct, and I'm okay in math, that was 20 years ago. That was a long time ago. This was well ahead of its time. And it led to a randomized trial, R2G 9901, but it was closed for lack of accrual. And probably one of the biggest reasons it was closed is the NCI did not want us to include stage 3 in this trial because it was being done in GOG 122. So we only include early high-risk patients, and it was probably a little before its time. This is a trial I couldn't get my gynec to put people on because he didn't want to give Taxol to early-stage patients. But if we could have successfully done this, I think it would have been a nice trial and some good results, and we'll talk about who did it, which was PORTEC. But there are some other randomized trials. This is the NSGO EC 9501 EORTC 5591, which was done between 1996 and January of 2007. And it's radical surgery, they call it radical surgery, THS-BSO plus a pelvic lymph node dissection. Stage 1, 2, or 3A, or stage 3C positive pelvic lymph nodes alone were in this trial. So high-risk patients. Patients with serous clear cell or anaplastic carcinoma are eligible regardless of other risk factors, so include high-risk histologies. And a simple randomization between radiation or radiation chemotherapy, and a little bit of a hodgepodge of chemotherapy, but it was radiation or radiation chemotherapy, similar trial as the R2G 9901 did. And when it came to progression-free survival, the chemo RT group did better than RT alone. This is an interesting slide, and I'm sure all of you read an editorial I wrote in the Japanese Journal of Gynecology. You're laughing, that means you didn't? I'm going to try to outdo Anthony. I don't have any funny pictures. What I wrote was there's not a lot of evidence to give chemotherapy for serous and endometrial cancer. It's not the same as serous ovarian. And this is interesting that in this randomized trial, when you look at progression-free survival of serous or clear cell, it wasn't positive. I know every one of your gynecs gives chemotherapy for serous endometrial cancer, but the data is not that great, and this did not support that. Just an interesting side thing, my own biases. We argue about radiation, which causes, in my hands, no morbidity, in your hands, a little morbidity, but we give chemo that's really kind of toxic for lack of a lot of data, especially when it comes to neuropathies. And you all see patients that really struggle with their neuropathies for a long time. So this led to PORTEC 3. Again, Karen Kreutzberg and their colleagues do a phenomenal job at doing trials, and I think they do a great job of accruing and getting these done fairly quickly. And this was presented at ASCO last year, I think now, and it's endometrial cancer, stage 1. The eligibility criteria was stage 1, grade 3 with deep invasion or LVSI, stage 2 or 3, or again, stage 1 to 3 serous or clear cell carcinomas, constituting more than 25% of the tumor. Good performance status, no residual macroscopic tumor after surgery, and they learned their lesson from the other PORTECs. They had to have their path reviewed before randomization, so they didn't have to go back and redo it. It was a fairly simple design. It was the RTOG design, 9701, which is my kind of standard treatment, actually, although I'm tweaking it a little bit. It was pelvic RT, 48.6 gray with 2 doses of cisplatin during pelvic RT, followed by carboplatin for 4 cycles versus RT alone. Uniform treatment schedule, upfront pathology review, and quality of life analysis was included. A very simple, clean trial. It's RTOG 9901 done. That was their regimen they chose because of the data that was very reasonable. The tumor characteristics, they were pretty well balanced. About 40% of the patients had grade 1 or 2 disease, 30% had grade 3 disease, and 30% had serous clear cell or other histologies. LVSI, about 60% of the patients had LVSI. Remember, generally 20% of endometrial patients have LVSI, so obviously this is a high-risk group, so it's a higher risk LVSI. And then stage, about 30% stage 1, about 30% stage 2, and about 50% stage 3. So this was a mixed group. It wasn't just stage 3. It was a high-risk group of patients. The surgery, there was about half the patients, 40% of the patients had hysterectomy alone, and about 60% had lymph node dissection. So again, a little bit mix of who went into the trial. But a good RT completion rate, 99% completion rate, as opposed to the Aztec trial that had 80%. So good radiation and done well. CT completion, most patients got through 2 doses of the cisplatin during the radiation. And probably a good number, 70 to 80% is a good number to get through all 4 cycles of carbotaxol. So pretty good treatments. The results, the 5-year overall survival in the chemo RT group was 82% versus 77% in the RT group. That was not statistically significant, but I always think when I talk to residents, what does statistically significance mean? It means that the chance that this was random. So it's still an 82% chance that it was real. If they had more patients and powered it differently, it may have been positive, but it wasn't positive in the entire group of patients. When it went to 5-year failure-free survival, it was 76 versus 69%. Again, not statistically significant if you're using a p-value of 0.5, but getting closer. So it did give a hint that this might be a good thing in high-risk disease. The first site of recurrence in the chemo RT group, distant was 22%, about the same. This is the same numbers throughout these trials. When you talk to your patients, you can tell them about what their risk of distant recurrence will be. In the RT group, it was 28%, so about 5 to 6% difference, which we saw in the other trials. The pelvic recurrence rates were low in both arms. Either about 1 to 2% was a pelvic recurrence rate. And I'll get back to that when we talk about GOG 258, which is what conceptually bothers me a little bit about the results of that trial. Vaginal recurrence rates were low, and you can see the rest of the data. Again, distant-only recurrences were slightly higher with RT, but it wasn't that much different. And this is kind of the failure-free survival from multivariate analysis. Treatment, chemo RT, p-value was significant in multivariate analysis. Stage 3, age, serous, endometrial grade 3, LVSI, all statistically significant. Lymphadenectomy did not reach statistical significance. So the risk factors we would think would be risk factors for a higher risk disease were true, but this is probably the main take-home from the trial is the survival per stage. So if you look at patients with stage 3 disease, they had a lower 5-year freedom from FFS, I can't even say that word, and overall survival was 64% for stage 3 versus 79% for the lower stage, which you would think is right. Stage 3 disease has higher risk. Overall survival was also less. They also had the greatest benefit from the addition of chemotherapy. 5-year failure-free survival was 69% in the chemo RT group versus 58% in the RT group. almost a 10% difference, a pretty good difference in survival. The 5-year failure-free survival and the 5-year overall survival tracked that, which was about a 10% difference in survival with the addition of chemotherapy. So the conclusions, there's a trend for improved 5-year failure-free survival in the entire group of patients, but it was significant in the patients with stage 3 disease. They did have more toxicity, and the overall survival analysis may need longer follow-up. I think this adds to the data that for sure, probably, good English, I think the stage 3 patients, there's more and more data that the standard of care would be giving chemotherapy, which leads to us, do we give radiation? And that's really the hard thing to discuss now with this data. So again, this summarizes some of the, and I borrowed these slides from the presenter from GOG 258, which I actually also happen to be a co-author on. GOG 122, we talked about this. These are some randomized trials. Local recurrence rates were higher in the non-radiotherapy arm. Distant recurrences were higher in the whole abdominal arm, and the survival was a little bit better with chemotherapy. GOG 184 was external beam radiation followed by 2 different forms of chemotherapy. Local recurrence rates were about 10%. Again, getting back to that, remember PORTEC was only 1%. So that in the GOG 184, which is a randomization of 2 different types of chemotherapy, the local recurrence rate was relatively high, I think. The distant recurrence rate was about 30%. The 5-year relapse-free survival was 56 to 59%. No difference between the two chemotherapies. That trial actually established carboplatin and paclitaxel being the chemotherapy arms. In the MAGI trial we talked about, again, no difference between the two, which led to GOG 258, which is almost in press in, can I say that? Yeah. So it should be coming out soon. The authors have been doing a lot of work to get it through, and that's really good. So it's TAH-BSO, pelvic and periodic lymph node sampling was optional. The eligibility was stage 3 disease or stage 4A disease. Most were stage 3. Stage 1 or 2 clear cell or serous with positive cytology was also an eligibility criteria. Good performance status, adequate organ function. Ineligible carcinosarcoma was not on this study. Recurrent endometrial cancer or residual tumor after surgery greater than 2 centimeters. So similar eligibility to GOG 122. It was a 1-to-1 randomization. Cisplatin given days 1 and 29 plus volume-directed radiation therapy, which meant pelvic plus minus periodic, depending on if there was periodic disease involved, plus minus brachytherapy, followed by carbo and paclitaxel for 4 cycles, versus regimen 2 was 6 cycles of chemotherapy with a higher dose of carboplatin. So they're different chemotherapies, different ways of giving different chemotherapies in a trial. The other thing I point to is that I don't know if you get grief, I get grief when I try to get follow-up imaging on these high-risk patients. I think it's more important, obviously, if you didn't give radiation at all, but this trial did get follow-up imaging, CT scans every 6 months for 2 years and every 12 months for 3 years. Something to think about, because I get grief for getting imaging in cervix cancer. I like to give imaging if I don't treat extended field, because I think that if you catch a periodic recurrence before it's symptomatic, you can maybe salvage a patient. So there are some data. This is a discussion I use with the insurance companies, is that the trials often got imaging. It's a personal decision. The patient characteristics were pretty well balanced. The median age was 60. About 80% of the patients in both arms were Caucasian. Performance status was good. FIGO staging 2009. Most of the patients, 75% of the patients, were stage 3C. Histology grade was, as you can see, there's about 2% of the patients were clear cell, and about 7% were mixed epithelial or other, and about 20% were serous. And then the BMI you can see. The characteristics of the patients, chemo-RT, group 174 patients received external beam radiation, no brachytherapy, 201 got brachytherapy. About 352 of the patients received 2 cycles, and 310 received greater than 4 cycles of carboplatin. In the chemotherapy arm, 374 received greater than 4 cycles or equal to 4 cycles. And the reasons to come off study are noted. And this is the data. So the cumulative index of recurrence, Vaginal recurrence incidence with the chemo RT arm was 3%, the chemotherapy arm was 7%, and there was a doubling of the pelvic or periodic recurrence rates at 5 years of 20 and 10. I just think 10, if you add these two up, 13% local regional recurrence rate in patients that got radiation seems a little high to me. It'll be interesting to see what the actual patterns of recurrence was. If you're not giving good radiation, you're not giving good volumes, were people recurring in periodic nodes that weren't dissected? It's just something that I think is interesting and awaiting further evaluation. The distant recurrence rates, again, remember that number between 20 and 30% is pretty consistent in all these groups, was 6% higher in the chemo RT arm than in the chemotherapy arm. I'm not a statistician, but these look similar. The overall survival between chemotherapy and RT was similar. So the question is then, should we be giving RT? I think that's the biggest question. So there's no improvement in survival. There was reduced local regional recurrences, but increased distant metastases. So is it worth giving patients radiation? You know, there's some nuances of this that are a little concerning. Chemotherapy was reduced in the patients receiving the combined treatment arm. So if you believe in amount of chemotherapy given, they were purposely given less chemotherapy. And albeit in a different population, the chemoradiation arm PORTEC-3 had a very low rate of local regional recurrence rate, while this one has 13%. So the exact patterns of recurrence and high recurrence rate in GOG 258 needs to be described and discussed. And chemo RT certainly reduced the risk of local regional recurrence, but did not have any obvious effect on overall survival. And the exact role of radiation specific of delivery will need to be determined. I think that the reports of my death have been greatly exaggerated. I don't think we should not be giving radiation advanced endometrial cancer. I think it's a more nuanced discussion. I think that we could probably improve on the delivery of this treatment. I think waiting so long for the chemotherapy to be given in the RT arm and then giving less chemotherapy may have played a role in why the outcomes were a little bit worse. So what we've done, we have a phase 1 trial that we started where we're giving chemo RT, we're giving full dose carboplatin first, then we're giving low dose carboplatin with external beam radiation, then more chemotherapy to try to get the chemotherapy the same and get it a little bit earlier. Not saying that's what we should do, but that's what we're kind of thinking out of the box, what we can do differently. We are still treating. I'm still treating with pelvic radiation for high-risk patients or involved field radiation. And then I love this line, which is, I think, true. There are 3 kinds of lies, damn lies, and statistics. You can make anything sound any way you want. I can tweak any data you want to say what you want to do. But this paper will be published in the New England Journal of Medicine. I don't know if it's what the outcomes are going to be for the payers and stuff. There was some wording at the end that I thought should be changed. I don't know if it got changed, but we'll see. So for stage 3 patients, I think their conclusions can be that both PORTEC-3 and GOG 258 and GOG 122 support the use of chemotherapy. So I think that's clear. So if you see a patient with stage 3 disease, they probably deserve chemotherapy. The role of radiation in these patients are yet to be determined, although it's certainly reasonable to deliver radiation to at least improve local regional control. 20% is a pretty high recurrence rate, and it's pretty morbid to try to salvage these patients. So I think it's a more nuanced discussion. I don't think it's wrong to give chemotherapy alone by any means, but I think that you can make your own decisions. So I think some places, I know Memorial does this, and I've done this too, you know, someone has a single small lymph node metastases but no other risk factors for local regional recurrence. Maybe those are the patients you might want to not give radiation to, but I think that's a discussion you have with the patient. I always give vaginal cuff for these patients because I don't think it adds any morbidity. We'll talk about, for chemovaginal cuff radiation, I give it right away. There's no reason to wait. So I usually give it between the first and the second course of chemotherapy. I don't give it the same day as a chemotherapy, but I think giving it after all chemotherapy doesn't make any sense. You can easily give it during, and we published a paper that the morbidity of that was next to nothing. So that's just how I do it. But if you look at the data of pelvic recurrence and advanced disease, we saw GOG 258 was 20%, still waiting for more follow-up. But in other groups, AJ's group, when he looked at it, when giving chemotherapy alone at U of C, it was fairly high. It was 40%, with 53% being non-vaginal cuff. My own thing with radiotherapy was about 10%. We talked about GOG 122, and then in our paper where we looked at 3Cs in my last institution, we had no local regional recurrence, which makes me wonder if I should go back and look at the data. 0 is never correct, so I hope that was correct. It was honest. It wasn't dishonest, but it makes me feel we didn't find all the patients. So I think that's probably a reasonable conclusion when it comes to advanced endometrial cancer. Always give chemotherapy and at least talk about the risk of giving radiation. I still give it, but I think that's going to be a personal discussion. So now for something completely different, medically inoperable endometrial cancer. I do have a talk tomorrow about brachytherapy, about techniques and stuff like that, so I'm not going to talk about that with medically inoperable, but I've seen this more and more. You know, it's kind of rare and kind of not rare. It depends on your gyne-oncs. There are challenging clinical scenarios, medical comorbidities, obesity, advanced stage, relative contraindications, anesthesia. I think this is important that the patient be seen by a gyne-onc if someone says they're medically unresectable, because medically unresectable is a very moving target for different surgeons. I think approximately, a lot of the data says approximately 3 to 9% are medically inoperable. This will become more and more of an issue as the years go by, as people get more and more comorbidities. I think definitive radiation can be considered as a curative measure. You look at all the data, we don't seem to change survival, because if they're truly medically inoperable, they're probably going to die from their other disease, but you can consider it. Progesterone therapy can be considered as well, and maybe considered to bridge a patient with comorbidities of surgery. There's all sorts of options when someone can have surgery. These are the historical disease-free survivals. I want you to memorize this. No, I'm only kidding. It's purposely very detailed-oriented, but just to keep it simple, the disease-free survival and disease-specific survival is between 60 and 80% for stage 1 or 2 patients treated with definitive radiation. I always tell patients it's about a 20% difference in local control decrement with radiation versus surgery, and then adjuvant radiation if you need it. So it works, it just doesn't work quite as well. And then again, looking at historical series, the disease-free survival and disease-specific survival for stage 1 or 2 medically inoperable is about 70 to 90%. So you do pretty good if you treat. What you do for the workup, pelvic examination with clinical staging, you can consider sounding the uterus to determine the size of the endometrial cavity. And then obviously you probably should have a biopsy. And this is the old clinical staging system, which I still use for my medically inoperable patients. Stage 1 is confined to the uterus, and if you do a sounding, there's a 1A and 1B between less than 8 and greater than 8 centimeters. Stage 2 is obviously gross involvement of the cervix. Stage 3, perimetrium, adnex, or vaginal, but confined to the true pelvis. And stage 4, rectal, bladder, or metastatic. So just to kind of give you an idea what the local regional recurrence is. Again, the workup, pelvic examination, biopsy. Cross-sectional imaging, I think, is important. If you can get it, CT or MRI for lymph node evaluation. But I think MRI is important because it gives you a choice to look at the local extent of disease, and that is where I do make a difference in my treatment. Get T1 and T2, include pair orientations of sequence, and consider PET CT for lymph node evaluation. It's a little bit better sensitivity and specificity, but I won't get into that debate. Depends on what you're doing. The reason for this is that you're trying to decide between what kind of therapy you're given. And again, imaging, staging, preoperative MRI from the French in 91 patients, and then had surgery afterwards. It correlated pretty well. So depth of invasion was about 82% accurate, cervical invasion 90% accurate, no positivity 79% accurate. About 2/3 of the patient, the stage corresponded to the MRI stage. So it's a reasonable staging system. It can give you some good idea what the depth of the invasion is. And then another one from Korea did 528 patients with about a 68% stage concordance. So it's a reasonable staging in patients that can't have surgery. And then this is just a stage 1 endometrial patient, T2 weighted MRI image showing the distension of the endometrial cancer and whether there's any invasion of the myometrium. It does not have a little heart, though, for Valentine's Day, and I apologize that. And this is obviously a disease that's a little bit more invasive into the myometrium. And why is this important? Because I think it will do difference in how you treat the patient. So obviously this patient has obvious myometrial invasion, and I'm not going to go through that, but we talked about the imaging can be used to try to be a surrogate for your surgical staging, going back to GOG 33, whether you're going to give external beam radiation. So all the staging you do preoperatively kind of helps determine whether you're going to give external beam radiation, because I do think everyone needs to get brachytherapy if you can. And this is a National Cancer Database presentation from Sushil's group, and it was primary radiotherapy for non-surgically managed stage 1 endometrial cancer, utilization, impact of brachytherapy. They had 853 patients they found, and there was a lower use of brachytherapy in older patients. The median survival was improved with brachytherapy. It was 24% in external beam alone, 31% in external beam brachytherapy, and 45% in external beam and brachy. External beam radiation had inferior survival. Brachy alone had equal survival. Now this is, again, bad data. Not that's because I didn't write it. It's just bad data. But it gives you some hint. You can make the argument that the people that got brachy could get brachy. So that's a difference in survival. But it does kind of suggest that if you can give brachy, try to give brachy. Again, another database. This is a population base with using the SEER endpoints. Again, external beam radiation alone or brachy plus or minus external beam with 3-year overall survival and cause-specific survival are better. So the take-home message is get an MRI if you're going to treat, which is, again, another discussion. If the patient's life expectancy is not that long, I'm not sure you should treat. But if they have a reasonable life expectancy from their comorbidities, I get an MRI, decide if there's enough invasion or other reasons to give external beam, but always do brachy if you can. And we'll talk about techniques for brachy tomorrow. And I think the other take-home message is one person's medically inoperable is not another person's medically inoperable. And I've actually had patients where they've gone to gastric bypass and waited till they got better health and then had surgery. There's always options. A lot of time it's the morbidities that are going to cause their demise, and talking to them about making better choices is a good thing. So now again for something, I told you this was a hodgepodge, sorry about that. Should IMRT be considered a standard therapy in post-operative treatment of endometrial cancer or post-operative treatment of gynecological cancers? It may decrease the risk of severe sequelae. Certainly there's a bunch of dosimetric studies that show it's better. And preliminary outcomes have noted low toxicity rates and excellent pelvic control rates. So we at RTOG did a phase 2 trial just to see if we can do it, just to see if we can teach it. The original Gyne Atlas that we developed was for this trial, so we had something that people can look at. It was RTOG 0418. We talked about the fact that we're going to update that, and I gave you a little bit this morning that we're going to better define the obturator nodal regions, remove bony landmarks, give recommendations about rectal distension, I don't know what they're going to be, and include common iliacs and periortic nodes. And again, we don't have to belittle this, but IMRT versus conventional pelvic RT has better dose-volume histograms, which is not surprising. And the clinical outcomes in some limited trials have shown good control with reduced toxicity. So this is RTOG 0418. I'll give a little bit more specifics of it because it's got a little bit better follow-up. And the primary objective was to determine the transportability of pelvic IMRT for patients with endometrial carcinoma to a multi-institutional setting. So I think we did this right, meaning you can't just tell people to give it. It is complicated when you first start doing IMRT. And then also to sense the adverse effects, test a hypothesis that it's lower toxicity and estimate the rates of local regional control. Chemotherapy was not allowed in the endometrial arm. We talked about the guidelines. There were dose volume constraints that were asked to be delivered. We did do an ITV. It's a controversial point, and I'll talk about that later. Doses in nodal PTV, vaginal PTV with the ITV margin was 50.4 gray and 28 fractions. And if you want to give brachy, you can give brachy. We did do central IRB quality assurance, and I'm going to show some of the pictures. The first case from each institution was reviewed by 1 or 2 of the PIs prior to the treatment, and the second case could be reviewed at the discretion of the PI. So if they did a good job in the first case, they didn't have to look at the second case. Adverse events were CTCA version 3.0, and primary endpoint was whether you can do it. And then with secondary endpoints were assessed these purposes. This was open from 2006 to 2007. 58 patients enrolled, 43 were eligible. Median age was 57, median follow-up was 3.5 years. And you could look at the overall survival and disease-free survival. But some of our colleagues, when they first started doing IMRT, had interesting contours. So this is, what's wrong with this contour? The vaginal CTV and PTV were simply circling the obturator. This person put the volume a little low, not sure why. This person, when they first did it, just circled the vessels as their CTV. And obviously, this person didn't include the external beam, the external iliac artery. So at least when we started doing this, most of the contours had to be tweaked. Just a lesson that if we're doing new technology, it is good to kind of do some quality assurance and make sure people are doing it well. And this is just someone treating a little low. But what I want to bring up in this was that the patients treated with pelvic IMRT and RT-0418 could get weakly cisplatin if they got cervical cancer, and that we did an ITV, and this is something that I'm struggling with the update of the Atlas about what we should say we should do. Why did we do an ITV? This is a patient of mine. This is an ITV, meaning we took a scan with a full bladder and then have them empty the bladder and do a scan. This is not atypical. This is 20 seconds later for just getting up and urinating. Their vag cuff can move a lot. So at least whether you have to have an ITV in these volumes, you at least have to account for the motion. Again, this is the same patient between the full and empty scan 2 minutes later. What I'm struggling with is there are different ways to do things. Could you do this by giving a bigger PTV in that area? Do you really have to do a full and empty scan? We do IGRT. Can you simply make sure the bladder is at a certain level every day? There are other ways to do things when it comes to IMRT for the pelvis, but you do have to take into account that bladder filling, rectal filling can move these volumes a significant amount. So what I do in practice is I do an ITV, but I also look at the cone beams. I typically get a fair amount of cone beams during treatment, and I've had patients where their full bladder becomes fuller and it moves the vaginal cuff out of my PTV and I have to replan. It's just something you have to think about when you're treating, because it does move a lot. And some of the results, there was only the overall survival, there was only 4 failures, 95% survival, so survival was well. The disease-free survival was good. Local region recurrence rates were 7%. Is that high? Maybe. And I think that we should be looking at this in 258 and 249 and looking at the exact patterns of recurrence to make sure we were treating the right areas. And I won't talk about that. There was a signal that the toxicity was less in 0418. So the conclusions were it was feasible, although it was fairly detailed quality assurance. Grade 2 and higher small bowel seemed to be reduced by about 40%. Contouring the organs at risk were actually pretty good. Most people can do that. Contouring the nodal and vaginal tissue had some major deviations that were corrected before treatment, but concerning that there were so many. This did lead to the randomized trial, has been published in JCO, of NRG R2G 1203, standard versus IMRT for pelvic radiation for postoperative treatment of endometrial and cervical cancer, the TIME-C trial. I think you have to have an acronym, and I think the Brits do that much better. PROTECT is a much better acronym than TIME-C. But this was women that were getting endometrial cervical cancer requiring postoperative RT. RT was 45 to 50 gray, no chemotherapy in the endometrial arm. Disease sites were endometrial and cervix. A simple randomization between IMRT or four-field. I think this is important for our field. Oftentimes we will take new technical things and just say they're better because they look better on paper. It is nice to take a new technical thing and actually test whether what you think is happening is happening. So I do think the NCI funding this trial was an important thing. The primary endpoint was to determine if GI toxicity was reduced by MRT after 5 weeks of radiation, use a patient-reported outcome measure of toxicity. I also think pros are the way to go with outcomes. It should matter to the patient, and they should be actually giving the history. And it was simple questions. How often do you have rectal urgency, uncontrolled leakage of stool, stools that are loose, bloody stools, your bowel movements painful, how many bowel movements, how often do you have crampy pain in your abdomen and pelvis? So things that really were important. Bowel bother, how big of a problem? Has each of these issues been for you? Has your bowel habits been, how have the bowel habits been for you? So very practical questions for the patient, not how many bowel movements do you have a day as the endpoint. And this is the EPIC bowel score, which was statistically significantly improved by IMRT, and that was taking in all those questions together. And the bowel source summary, again, was less 0.048, just barely statistically significant, but statistically significant. Bowel function was significant, bowel bother was not as a whole. And this is, again, bowel function the last 7 days. Did you have loose or watery stools? And this was at 5 weeks. And bowel bother, you can see there, how much pain did you have in the abdomen, how much loss of control did you have. And when you look at IMRT versus standard radiation, frequency, interference, diarrhea was all significantly improved with IMRT. Use of anti-diarrheal medications was also better with IMRT. So I think we've proved that what we thought was happening. The pelvic RT reduces acute patient-reported GI and GU toxicity compared to standard pelvic RT, reduces the need for antidiarrheal medications, improves quality of life, and then we'll just need longer-term follow-up to suggest whether this improves long-term outcomes, but it should. I think there's more and more data that short-term outcomes portend long-term outcomes. So I think that the answer is that I think the standard of care for postoperative gynecological malignancies is to give IMRT. And when we published this paper, we no longer had denials from insurance companies, which really helped. So the practice of postoperative IMRT in gynecological malignancies, it goes without saying, but the CTV should be accurate. Seems logical to me. And I think internal target motion must be accounted for. Don't know how you're going to do this, because simple cone beam CTs, you can't move your cone beam CT to the vag cuff, or you'll move the nodal volume. So you either have to have a PTV or different plans, or you've got to just think about how you're going to do it. I don't think there's a right answer. I think an ITV is critical, but I'm kind of backing off a little bit on that myself, because I think cone beams have gotten better so you can see things a little bit better. So maybe a bigger PTV around the vagina is just as good as an ITV. So I won't be as judgmental as I used to be, but you just have to take it into account. And then post-treatment complications of all this stuff. We talked a little bit about time C, but I want to take a step back to some of the older trials, because some of the gynecologists will use that as a reason not to give radiation. And in PORTEC 1, the long-term quality of life SF36 scores make radiation look pretty bad. This is very, very concrete trials, which remains close to the toilet related to urinary control, urinary incontinence, or bowel symptoms, were really pretty bad long-term in PORTEC 1. Suggesting that maybe we shouldn't be giving pelvic radiation, because there's no obvious data that it improves survival in advanced disease, and look at how horrible it was. But what people don't talk about is this is the techniques that they use in PORTEC 1. Just like Dr. Zeitman showed the thing we used to treat where we just drew things around on a wax pen and hope nothing was in there. Only 52% of the patients had a 4-field technique, and they had a 5-year complication rate of 21%. 18% had a 3-field technique, had a complication rate of 36%, and 30% had APPAs with a complication rate of 30%. The 5-year actual rate of toxicity was 26 versus 30, depending on it was 4-field or other. So nearly statistically significant for technique and complication rates. So I think, yes, it looks bad, but I don't remember the last time I treated somebody with a pelvis APPA, probably 1960. Well, I wasn't alive then. We touched on this on the other trial, vaginal length or vaginal brachytherapy for endometrial cancer. Do we really need to tell people survivorship stuff? This was published by Dr. Bruner and looked at 90 patients who received intercavitary RT after treatment for cervical or endometrial cancer, and they took measurement lengths every 6 to 12 months and then yearly, and looked at the vaginal dilator compliance rate, which was 68% of using it 1 or more times per week. What do I recommend? I recommend 3 times a week, and I usually tell people either dilate or intercourse. And if I had $1 for every funny comment I got about that, especially from my 85-year-old, and I know I do not have a dating service, and no, I can't help you with that. And this is the results from that trial. Even in endometrial cancer, there is a decrease in mean vaginal length after RT. Don't know if that means anything, but it does decrease. This is one of the only toxicities we see. So we did a randomized trial to assess changes in vaginal length from pre to post vaginal brachytherapy for endometrial cancer in patients prescribed with vaginal dilators. And it was a randomization of teaching. So we had a randomization of standard teaching, which I don't know what you guys do, but I say, the nurse is going to talk to you about the dilator, and they give a dilator and a page and say, yeah, use this 3 times a week, and they're never going to do that. So our standard teaching is not very good teaching. So the standard was to give a smooth plastic dilator, tell them to begin 2 to 4 weeks after vaginal brachytherapy, give instructions, encourage engagement in sexual intercourse, and attention controlled. We call the patients at 1, 4, 12, and 18 weeks. The enhanced was a more instruction, some more modeling. And then we used the endpoint was a vaginal length sound to assess the length of the vagina at different endpoints. So try to get some data behind this vaginal dilator use. And the funniest thing is we wanted to have a primary endpoint being female sexual function. And I was having a heated discussion with Dr. Bruner about what that endpoint would be. And my 16-year-old daughter looks at me and goes, "What are you doing?" And I said, "Well, this is work. I swear to God, this is work." So it was it was a endpoint we really couldn't come up with. So vaginal length became the endpoint. In the preliminary findings of the patients, it didn't seem to make a difference. These were patients that actually went on trial. So about half the patients were using it 2 to 3 times a week. Others were not using it very often. The Australians asked their women, especially for cervical cancer, to use a dilator every day. I'm like, wow, that's kind of mean. I say 3 times a week forever, but I don't think there's a lot of good data. So there was no difference in vaginal length from before to 6 months after for endometrial cancer, but an increased dilator use may be beneficial in preventing loss, or according to Dr. Bruner's last trial, there was some loss in length. Does that really portend in a better female sexual function? We don't have that data either. So this is, do we give a dilator? Probably. Does it help? Who knows? I do tell patients it's easier to see the top of the vagina if they use it, because it does get a little agglutinated if you don't. We touched on this subject. So the only other complication of vaginal brachytherapy is secondary malignancies. And this is some SEER data that was published in the Red Journal in 2010. If you had no radiation for endometrial cancer, you actually had less observed to expected. In addition, if you had brachytherapy alone, there was less observed to expected. Do I think that's because you prevent second cancers? No. I think it's because they're in the health system. And my follow-up is also follow-up for primary screening. So mostly I think this is good people do their colonoscopies. But with external beam radiation alone, there was a 1.1 increased risk of second cancers. It was higher with external beam and brachy, and that's what I have seen. I have seen an occasional vaginal cancer with this, because I do think we used to give a very high dose at the top of the vagina. And this is years after endometrial cancer diagnosis, colon cancer. These are still very low numbers, but there was a difference between any radiation and radiation when it came to colon cancers in this analysis, at least. And then this is cumulative index of vaginal cancers. And again, you see that these things get pretty wide apart as the years go by. So like I said, my standard has been to get a pap smear after 10 years, and I've caught a couple vaginal cancers. And this is bladder cancer. Again, these numbers are low. This is 1% to 2% difference, but they are real. If you look at the SEER analysis, so it's something just to keep in mind when you're talking to patients. I don't think it's a reason not to do it, but it's a reason to make sure you're following up on their symptoms. And that's it. Any questions?
Any questions?
Thank you very much. So when I'm contouring my IMRT for post-op endometrial, for example, I always feel kind of funny about where I start connecting the H, bringing that band across to treat the top of the vaginal cuff, because on the contouring atlases, it starts kind of an arbitrary point, and it doesn't start where you see the remnant of the vagina. It starts higher, but where you start drawing that always seems kind of arbitrary to me. I always start drawing it where I see less bowel. I always feel funny connecting the two, nodal bands where you're going through small bowels. So is there any kind of guideline to kind of objectively know where to start treating the vaginal, perivaginal tissues?
It's a great question. In fact, in both the first guideline we did and the updated guideline, the difference of opinion was from 0.5 to 2 centimeters above where you saw the top of the vagina. I don't think any of us have a real good definition. I do similar. I tend to be a little bit more generous because I'm not sure exactly where we're supposed to start, just in my practice. I think the biggest problem we've seen is, and the biggest problem we're going through with the update of the guidelines, the CTV can look pretty small, especially in that area, but we know it moves a lot. So the PTV, if you don't have an ITV, especially the PTV needs to be generous, or you have to have good IGRT. I think that's the biggest point, is although it's arbitrary where that vaginal cuff is a little bit, we do know it moves around a lot. And 45 to 50 gray is pretty safe in that area, so I think the major problems I've seen is being too tight.
Sorry, correlate. Do you ever tell patients to come with a full bladder every day to try to minimize the motion?
My typical is a full bladder, comfortably full bladder.
Any other questions?
It was just so that clear, or you just want to get outside, which I don't blame you.
And we can go ahead with the SAM quiz.
All right.
Then.
So the main outcome of GOG 122, a randomized trial of chemotherapy versus whole abdominal radiation, was 1, whole abdominal RT was associated with improved survival in high-risk endometrial cancer compared to chemotherapy. 2, whole abdominal RT was associated with reduced survival in high-risk endometrial cancer compared to chemotherapy. 3, whole abdominal radiotherapy noted similar survival compared to chemotherapy. or 4, the study was closed due to lack of accrual. And Jim, don't purposely answer wrong. So the question 1 was HOPE-NOM-RT was associated with reduced survival. It wasn't similar, it was reduced. And then, of course, this was the main trial that started chemotherapy and endometrial cancer adjuvantly. So question 2, the greatest benefit of chemotherapy and radiotherapy versus radiotherapy alone in PORTEC-3 was seen in which patient group? Stage 1, stage 2, stage 3, or patients over 40? All right, 92%. I think people are just kind of trying to irritate me. Stage 3 patients appeared to derive the most benefit from additional chemotherapy, and there's multiple trials for that. GOG 258, the randomized trial that was reported and going to be published this year, randomized chemotherapy and radiotherapy versus chemotherapy alone in high-risk endometrial cancer. It noted what made the conclusion. Chemotherapy and radiotherapy was superior to chemotherapy alone. There was no improvement in overall survival with the addition of radiotherapy. Local recurrence was reduced by approximately 1/2 with the radiotherapy, or 2 and 3. Yep, it was no survival difference, but better local control. Okay. So in medically inoperable endometrial cancer treated with radiation, the most appropriate treatment for all patients includes, if you're, I probably should have written this better, if you're giving radiation, is external beam radiation, brachytherapy, chemotherapy, or hormone therapy. I apologize, it wasn't written very well. I'll blame it on having to write 20 of these questions. Brachytherapy, I think if you look at the SEER analysis and the NCDB analysis, I think brachytherapy is probably the main thing you should do in medically inoperable cancer. External beam radiation can add if you think there's a risk, but brachytherapy is probably the right thing to do for most patients, if you can do it. The main outcome of TIME-C trial that compared IMRT to 3D conformal radiation in postoperative gynecological cancers was, of course, there was increased recurrence in the IMRT group. Just kidding. IMRT and 3D had similar toxicity rates. Epic bowel scores were improved with IMRT patients, and diarrhea was increased with IMRT patients. All right, one good way to end, 100%. Thank you very much.
Thank you very much. Now we took a little break just a little earlier. I was realizing that if we just take a short break to change presentations and push on, then we can get our extra little talk in without too much running overtime. So let's just take a 5-minute break while we're getting things set up for the next presentation.
Good. All right, folks. This next talk is on the subject that I actually find pretty boring. When a resident says that they want to do a morning conference on, there are two things that just make me yawn. One is stage 1 endometrial cancer. I'm really sorry. But the other is post-op radiation for prostate cancer. But we'll try and keep this relatively short and make it reasonably entertaining. And tomorrow in my 2 talks, I'm going to use a lot of cases, clinical cases, to illustrate the various clinical situations that we're commonly faced with. This doesn't quite lend itself to clinical cases. So, why might we do adjuvant radiation after a prostatectomy? Well, we do it in breast cancer all the time. Lumpectomy, then you do radiation. We might do it after a prostatectomy because failure is common. It's really common after a prostatectomy. Overall, 30% of men who have prostatectomies will have a PSA failure. And that number is going up, not coming down. It's going up because surgeons are doing less prostatectomies on low-risk disease and more on higher-risk disease. And it turns out that failure is often local and it's often completely predictable. And it turns out that failures are best treated when the PSA is low. So as low as you can go is PSA 0, adjuvant radiation. So, emotionally, it makes a lot of good sense. So what proportion of patients with a rising PSA after a prostatectomy actually have a local component? Turns out it's pretty high. These are 2 studies. One's a classic study done over 20 years ago from UCSF. They had a new Japanese fellow, urology fellow, who didn't speak very good English. But he was a wizard with an ultrasound device. So they just said, look, you just do all our transrectal ultrasounds. And why don't you just biopsy all the guys with a rising PSA after prostatectomy? And he did very thorough biopsies of the prostate bed. And he actually found that of those with rising PSAs, 54% had detectable cancer within their prostate bed if you did enough biopsies. And that finding was verified, 41%, by another study done 10 years later. And probably 40-50% is an underestimate because there's got to be sampling error. I mean, he was just blindly biopsying. And we know from the days before PSA when we just, patients have prostatectomies and then we just let them fail. And also in the early days of rising PSA, we didn't know what to do with it, so we just let them fail. We know where they fail. They fail in completely predictable places locally. The commonest site of failure is the commonest site of failure is in the perianastomotic region. The second commonest site is the retrovesical. Just behind the bladder, just around the anastomosis and the bladder neck. Hence our classic salvage radiation fields. Where they look like a little toilet seat from the side, where the toilet seat lid captures the retrovesical space. All right, so we know where patients are going to fail if they fail. We know they fail commonly. And we know from, and I'll show this study to you again later, from pooled multi-institutional analyses, that the earlier that you treat with salvage radiation, the better the outcome seems to be. So why wouldn't we treat with adjuvant radiation? Well, we do. And there's plenty of level 1 evidence to support it. This is the classic Michel Bolla paper. I had the great privilege of, Michel Bolla is a larger-than-life Frenchman. I don't know if any of you have seen him speak, but I actually did a sabbatical in Grenoble with him a few years ago, and he's retired now, but he ran the department like a tyrant. A benevolent tyrant. And I, who am only used to the US system where we're so egalitarian, was because I was there with him, I was treated like the great professor. And I have to say, it was kind of addictive. I could get used to it very easily. Well, Michel Bolla is a magnificent speaker. Many of you will have seen him speak at Astro or Estro. And he speaks very colorfully in English, but when you see him speak in French, it is just glorious. There's a lot of beating of the chest and holding up the hands to the sky. And he's very passionate about this subject, adjuvant radiation for prostate cancer. This is the EORTC randomized trial. He was heading the EORTC at the time. 1,000 patients with positive margins or pathologic T3 disease who were randomized either to adjuvant radiation or watch and wait with treatment down the line. And you're all very familiar with the results of this trial. The number of biochemical recurrences was cut in half, which is pretty impressive. And that fits actually with the rebiopsy studies, which showed that 50% of guys have residual cancer in their prostate bed. So that was a very nice result, but you'll notice that both the curves are still heading downwards. And if you look at freedom from clinical failure, there was a significant difference. It wasn't so great. It was only about 10% at 7 years. But it was there, and it was significant. And why was there a difference between the biochemical recurrence and the clinical recurrence? Well, it may in part, and no difference in overall survival, I might add, it may in part be because of the management of relapse in the watch and wait arm. Those men, half of them didn't even get salvage radiation. Many of them just got hormone therapy. So it wasn't an absolutely clean trial. It was early. It was adjuvant early radiation versus late, perhaps a little bit too late salvage. One thing that did emerge from that trial was the guys with the positive margins were the ones who really did seem to benefit from the adjuvant radiation. This is hardly a surprise, but it's nice to see it confirmed. The other thing that was demonstrated is that there didn't seem to be much added to the morbidity of the prostatectomy. Their erections were no worse. In fact, they were terrible in both arms. But in terms of GU and GI toxicity, perhaps slightly worse, any grade toxicity in those who'd had adjuvant radiation, but nothing very profound. So the argument was, if we do them no harm, and we might do them some good, why not do it? But there have been 2 other randomized trials. In the middle, we have Michel Boller's trial, and on the left and on the right, we have a German trial and the SWOG trial. So there's an awful lot of randomized patients, and they all show the same thing. You cut the PSA failure rate in half. But the SWOG trial was the only one that showed that you actually had a reduction in distant metastasis-free survival, and that it actually might translate into a survival advantage. But it took 14 years to show it. So, and it wasn't an enormous advantage. So if you have a 70-year-old guy who's just had a prostatectomy and he's got some negative features, if you offer him adjuvant radiation, it's in the knowledge that he may never live long enough to see that benefit. And that benefit is only for 1 in 10 patients anyhow. So you can see why there's some reticence to do adjuvant radiation. But there are 3 randomized trials, and they do show a reduction in cancer recurrence. So when ASTRA and the AUA came together to develop some guidelines, they did it first in 2009, updated them in 2013, they didn't mandate that men with positive margins be given adjuvant radiation. But they did say that those with adverse pathologic findings should at least be informed that adjuvant radiation reduces their biochemical recurrence rate. And thus radiation should be offered. And yet, since those guidelines have been published, there's been a progressively declining use of adjuvant radiation. It's not like it's gone up any. It's actually been going down. Most patients are treated with prostatectomy alone, and then with salvage radiation or salvage hormone therapy at some point down the line, if it's considered appropriate. So there is some inherent resistance to offering adjuvant radiation. And the concern, I think the surgeons' concerns are that they put their patient through a prostatectomy, these patients are just about recovering their continence. Maybe some of them are on the verge of recovering their erections. Most of them aren't, but maybe some of them are. And you will reduce those quality of life outcomes if you offer radiation. There isn't much evidence of that, but that, I think, is the inherent concern, and why surgeons tend to are generally reluctant to do more than talk about adjuvant radiation. And they always say, well, this is not breast cancer. You know, breast cancer, there's no PSA. You know, so you give everyone radiation, even though the relapse risk is only 30% in the breast. But we got PSA, we can always pick it up early, which is not incorrect. So when do I offer adjuvant radiation? I can't say I give it, I offer it routinely. For those with extensive positive margins, I usually wait 3 to 6 months for them to recover their continence. If they're still incontinent at 6 months, I hold off. And I wait for the PSA to rise. And then maybe by then they'll either be continent or they'll have had their continence fixed. But I certainly have no interest in making an incontinent man worse. So those with extensive positive margins I will offer, but for all other high-risk groups I tend to wait, and I tend to treat on relapse. Now there are some really big trials going on, and this is the Australian-New Zealand RAVES trial. These are men who are at high risk after a prostatectomy, and they're randomized either to adjuvant radiation, where it's mandated that, or active surveillance, and then it's mandated that salvage radiation will be performed early, before the PSA reaches 0.2. So it's really early. It was opened in 2009. It has completed its accrual, so we'll be seeing the results from this at some stage relatively soon. So this is, unlike the 3 randomized trials I've shown you earlier, this trial actually looks at very, very early salvage. This is more what we do in practice these days. And then another shout out to the British. This is the Radicals ahead of schedule. And basically, men, they've divided men who've had prostatectomy into low, intermediate, and high risk for subsequent failure. Those who are intermediate risk, observation or adjuvant radiation, with early salvage baked in. Those who are at higher risk, they will get adjuvant radiation, and there the randomization is to hormone therapy, none, short or long. Wonderful trial, answers all the questions. To get back to what Bill was saying, so the British love acronyms for their randomized trials. They love them. And what you probably don't realize is that the national sport in Britain is soccer, football. And everyone is obsessed with football. It unites the entire nation. And Britain went through this sort of terrible phase of hooliganism, soccer hooliganism, in the 1970s and 1980s. That is completely eliminated now. But there's a kind of nostalgia for it. And so you'll find that a lot of the names for the randomized trials have a sort of slight sort of violent edge. You know, raves, radicals, you know, protest, protect. I mean, there's this element to it that is absolutely recurrent. So it's just something you might want to look out for if ever you see British randomized trials published. So, the timing of radiation after prostatectomy. What we're now going to see are trials looking at adjuvant radiation versus early salvage. I think what we were seeing in the first trials was adjuvant radiation versus later or even too late salvage. And that's not the way we clinically practice these days. Let me now say something about salvage radiation. With the obvious advantage of just holding off and doing salvage radiation down the line is that half your patients are going to avoid treatment. And that's a plus, unless you're in private practice, in which case it's a detriment. But it's a plus. Many patients avoid unnecessary treatment. But the disadvantage is we may actually lose an opportunity to cure. We don't know this yet. Just that SWOG trial seemed to hint it. But that is always a concern. And when it comes to salvage radiation, until very recently, we've had no published randomized trials available to guide our recommendations. You know, what dose, how much to give, to treat the nose, all this kind of stuff. But we're getting there. I will, however, say that retrospective studies certainly suggest, you know, there are true benefits to patients for salvage radiation if they have a biochemical recurrence, and there are many pooled multi-institutional analyses looking at the efficacy of salvage radiation. This is a rather complex curve, but if you if you start at the top and you head left, these are guys, we treat. PSAs are less than 2. Now, I mean, we usually treat the guys when their PSAs are 0.2 or 0.3, and, a nice low number. And if you follow the curves down, you can find certain groups with very high risks of, high chance of benefiting from salvage radiation. Equally, if you follow the right side of the curve, very low risks. And we mentioned this before, is there a PSA threshold for salvage radiation? Where should you start? When the PSA is 0.5, 0.2, less than 0.2? What if you've got the ultra-sensitive assay? 0.02? I don't know. None of us know. And it's not even clear because most of this is retrospective data. Maybe the guys whose PSAs are greater than 1.5 and doing badly, it's not because we waited too long. It may be that they just had the worst disease and they shot up quickly to 1.5 because they have METs. Whereas the guys we treat whose PSAs are 0.2 or 0.3 or 0.4 slowly got there. They have local disease. So there may be a huge bias in this. But I think intuitively, if we're going to do it, it feels right to do it when the PSA is pretty low. And there is plenty of other data. But none of this data tells us how low. So most of the randomized trials that have been written sort of bake in 0.2. I think when it's 0.2, we're pretty convinced it's not a bogus rise. Now, there are patients with PSAs detectable after prostatectomy of 0.08 or something like that, and that's not cancer, not necessarily cancer. It could be coming from salivary glands, from breast tissue, from the bulbourethral glands. If you check a woman's PSA, it will run somewhere between 0 and 0.1. So I tend to wait until the PSA is 0.1, 0.2, and there's a definite rising trend, because I don't want to treat someone who actually doesn't need treatment. Now, what about the radiation dose? All the trials have used doses of 60 to 66 gray. The RTFG trials, the ORTC trials, the SWOG trials, that's just what they've used. Is there any advantage to giving a higher dose? Well, if the disease is microscopic, there really shouldn't be. 70 gray, 75, where would the advantage? It's not like you're dealing with billions of cancer cells. But maybe there is. This retrospective data seem to hint at an advantage to higher doses, but dose of 70 gray or higher. But I wouldn't hang my hat on this. And certainly, there was no reduction in distant metastasis rate seen in this retrospective multi-institutional pooled analysis. So I personally do not push the dose higher. I'm far more interested in leaving the man fully continent and with a functioning bladder. So what do I think the retrospective studies teach? They teach us that salvage radiation can durably suppress PSA in many men, and there are plenty of men with rising PSA who are cured. Some unknown proportion of these men will live a subsequent life free from metastases or long-term androgen deprivation. That's a win. We don't know much about radiation dose. We know that doses in the 60s seem about right. We don't know much from these studies about adding hormone therapy to radiation. And we don't know anything from these studies about nodal radiation. So luckily, in the last 2 years, we have some randomized trials. This is one that I was very much involved in, RTOG 9601. It looks like a kind of nutty study when you look at it from the perspective of 2019. But it was actually written back in 1995. And it was salvage radiation, basically with or without high-dose bicalutamide. Where the hell did we get that from? Well, it turns out that the manufacturers of bicalutamide were prepared to give us the drug. It's a pragmatic trial. We could get the drug for free. And also, high-dose bicalutamide was being used as an alternative to Lupron for metastatic disease in those days. Very reasonable alternative. So that's how the trial was designed. Everyone got 64.8 gray to their prostate bed only, no nodes, and they either got bicalutamide or a placebo. Now, it turns out that bicalutamide is an incredibly powerful stimulant of gynecomastia. And even though we didn't know at time 0 which treatment the patients had got, by the time they came for their radiation, if they walked in like this, We knew. We knew. And this was, and they received their bicalutamide for a full 24 months. And these were the outcomes. There was a definite reduction in PSA progression that was durable. You know, this is 12-year data. About a 10% advantage to long-term hormone therapy of this kind, anti-androgen therapy. And actually, there was a reduction in metastases. By about 12 years, it was something like 9%. And in the end, there was a 4% improvement in overall survival. So you know, those are the benefits. 4% improvement in overall survival at 12 years. Now again, if you're treating a guy with salvage radiation age 70 and you're projecting into the future, you may say this is worth it or this is not worth it. That's a judgment you make with the patient. But I don't think this data tells you that you must use 2 years of hormone therapy. When we looked at subgroups, the advantage seemed to be greater for those with higher grades of cancer, Gleason 8, 9, and 10, and for those who actually had lower PSAs, less than 0.7, greater than 0.7, higher PSAs. So if you've got a PSA of greater than 0.7, if you've got a high-grade cancer, hormone therapy in addition to the salvage radiation seems reasonable. So this trial taught us that long-term high-dose bicalutamide improves 10-year prostate cancer-specific survival by 7% and overall survival by 4%. There's a hint that the benefit may be less in those with lowest PSA and lowest Gleason grades. We still don't know anything about radiation dose or nodal radiation. And, oh, one problem. High-dose bicalutamide is no longer FDA approved. That's a goof. We didn't predict that. It's not that. At the same time, in parallel with our trial, GETUG, the French group, were doing a similar trial using 6 months of a GnRH agonist. And this is a much more sort of pragmatic trial. You use a drug that's available. It use it for a period of time that seems reasonable to us. It's always a struggle getting guys through 2 years of hormone therapy. And they had a similar kind of advantage. Now remember that their trial is only at 5 years. Ours was at 10 years plus. And this hasn't yet translated into any kind of metastasis-free survival, overall survival advantage. So, but the data does look like our trial as it looked at 5 years. So maybe, reading into the future, we can say that 6 months of Lupron is sort of equivalent to 2 years of a high-dose bicalutamide. I don't know. Maybe. The difference between their trial and ours is that the hormone therapy seemed to advantage everyone across the board, even the lower PSAs and the lower Gleason grades. So that is a difference. But we don't know whether that's going to hold up and translate into anything. That may just be a PSA thing, as opposed to a real meaningful clinical thing down the line. So what does this trial teach us? It teaches us that 6 months of an LHRH agonist does improve biochemical survival at 5 years. Maybe it will at 10. The benefit was seen across the board. It isn't clear that 6 months is equivalent to 2 years of a high-dose bicalutamide, but we all like to believe it. And we still don't know anything about radiation dose or nodal radiation. So just emerging, presented at ASTRO last year, not yet a manuscript, probably not a manuscript for a while. The SPORT trial, RTOG 0534, rising PSAs after prostatectomy, and the randomization was salvage radiation to the prostate bed, salvage radiation with 4 to 6 months of hormone therapy, salvage radiation with nodal radiation, and 4 to 6 months of hormone therapy. And there is a real progressive increase in biochemical disease-free survival at 5 years. Not in any of the other clinical stuff. We're going to have to wait on that. But that's interesting. Maybe that'll translate into something. 5-year biochemical outcomes tend to translate into 15-year clinical outcomes. So maybe this is some important news. And another trial that's going on that has just given a preliminary report is a Swiss trial, the SACO 910. These are men given salvage radiotherapy, and they were randomized by dose, no hormone therapy, dose, 64 Gray or 70 Gray. They've closed with 350 patients. Their primary endpoints, which are freedom from relapse and freedom from distant metastases, are unreported at the moment. Some secondary quality of life endpoints, largely unreported. The only thing they've reported in an abstract form are their incontinence rates at 3 months. They're equivalent. You know, so I don't think this is telling us anything yet, but it might tell us something down the line. And certainly I hold off on the higher radiation doses for the moment. Still to come, there's a proposed NRG trial. It's salvage radiation with 6 months of an LHRH agonist. And half the patients will get enzalutamide as well. These are for the highest risk kind of patients, with those with the more aggressive features, high Gleason grade, seminal vesicle invasion, that kind of thing. I think it's a very interesting study, but it's going to be many, many years before we see the results. So this is certainly not standard of care as yet. So what's happening around the nation? So a couple of my colleagues have done some nice a telephone survey. Basically, they just ask their buddies, what are you doing at your institution? And if you look around, for high-risk kind of salvage radiation, most folk are giving a radiation with hormone therapy, and it's usually 6 months of hormone therapy. A few folk, the Mayo Clinic, Fox Chase, are giving up to 24 months for highest risk. And it all kind of seems reasonable to me. We've reached a consensus while waiting for these trials to mature. I don't know that, if you ask them whether they're treating nodes or no nodes, that's all over the map. If you ask them about dose, they're all over the map. So what do I think we should do in practice? I think in practice, 6 months of an LHRH agonist is totally reasonable for younger men, for those with adverse PSA and pathologic features. It isn't clear that 6 months is equivalent to 2 years, but I certainly hope it is, because shorter course of hormone therapy are kinder for patients. Remember, the British Radicals trial will answer the question of 6 months versus 2 years. I'm still with 64 to 66 Gray. I do treat nodes on occasion now because of the sport trial, younger men, highest risk features. And I don't do any hypofractionation. Yes, I'm an advocate of hypofractionation for an intact prostate. But think about, you know, when the prostate is absent, the prostate itself is just a fibrous lump that can take any dose or any fraction size. But when the prostate's gone, you are treating almost nothing but normal tissue. So I do worry about giving large fractions in the post-op setting, but it's being tested by the NRG. So again, we're going to have an answer there. And I must add, no evidence for protons as yet. So I think with that, I'm going to stop, and I'll take any questions. Then we'll do some CME. Yes.
Thank you. That was a great talk. I was wondering if you could comment on the use of Decipher or other molecular tests in making decisions about postoperative treatment.
These tests are out there. They're being used. We're waiting for validation, for good validation studies. I think they are going to be a part of the future. Interestingly, the only thing that drives a urologist to recommend adjuvant radiation is a Decipher test. They actually they've put more faith in these Decipher tests than our community have. But I think you will see this being increasingly used in the future. And I think it's going to become a stratification factor in many of the prospective trials. And it will be used as a way of picking up patients who are at high risk of relapse, and those who are at high risk of distant relapse, who probably don't need salvage radiation either. So it can work for us and against us, but always for the patients.
With the surgeons doing more radical prostatectomies on Gleason's 8 and 9 disease, are there any nomograms you're utilizing to assess extracapsular extension? The nomograms from Memorial Sloan and some of the others, Capra, they really don't give, I guess, the best numbers for ECE, some of them are very high and all over the map when we look at nomograms and compare them.
Well, no, we don't use any nomograms, but I will say the surgeons these days are, they've now done prostatectomies on so many men with high-risk disease that they can't promise. They've learned, if you promise them a cure, you're setting the patient up for disappointment. So usually, the surgeon and I see patients together ahead of time, and we warn them that the prostatectomy is probably only step one. If they're lucky, they might get away with just a prostatectomy. But we set them up to expect radiation or radiation and hormone therapy. And then, it's a bonus if they avoid it.
Any other questions?
So when you do salvage radiation, do you use when you're not doing nodal irradiation, do you kind of do a one-size-fits-all to the prostate bed? I know the RTG Atlas has go up to the vas deferens, where the vas deferens takes off. That seems kind of high.
That's it's an awful lot of of radiation. I will tell you that a bunch of us got together a number of years ago. In fact, we were all ABR examiners. I think it was the 9 GU examiners for the ABR, and we all drew our own on one set of CT slides. We all drew our own post-op volumes, and the difference between us was extraordinary. In fact, this was quantified. We only agreed on 9 cc's. So maybe that 9 cc's is where the action is. Maybe that should be treated with protons. All right, I think it's time to do some questions. All right. The most common site for a local recurrence after a prostatectomy is where? Is it the pararectal space? Is it within the urogenital diaphragm? Is it the perianastomotic region? Or the trigone of the bladder? Or the space of Retzius? If you even know where that is. Absolutely. Oh, very good. Perianastomotic region is where it is. Question number 2. When PSA rises following a radical prostatectomy and scans show no distant disease, how often does a rebiopsy of the prostate bed done by a Japanese urologist show local recurrence, or local persistence, we'll call it? Is it 20 to 30%, 40 to 50, or the others? It's actually 40 to 50% of the time, but I'm going to give you credit if you said 50 to 60% of the time, because the 40 to 50% is probably an underestimate because of sampling error. Now, regarding adjuvant radiation for pathologic T3 prostate cancer, its use is increasing. It's mandated by the AUA Astro guidelines. It's more effective at high radiation doses. All 3 randomized trials show a survival advantage. It reduces the rate of PSA relapse by half. Very good. And that is the take-home message. You reduce the rate of PSA relapse. And regarding salvage radiation, the target volume includes the entire bladder. Treatment of nodes is contraindicated if the nodes have been sampled. It should be performed before the PSA reaches 0.02 nanograms per mil. Doses of 60 to 68 gray are supported by prospective trials, or it's more effective when given with docetaxel. Very, very good. I mean, it may be that we'll change in the future. Sorry, can we just go back? It may be in the future we'll change. We'll be performing the radiation at a very much earlier stage, or that we'll be giving it with docetaxel, but we just have no evidence to support that yet. That one. That's it. And the fifth question, regarding the combination of hormonal therapy and salvage radiation, randomized trials have shown that 5 years of bicalutamide reduces recurrence. 2 years of anti-androgen therapy reduces the rate of distant metastases. 6 months of Lupron is associated with high rates of gynecomastia. 6 months of Lupron is equivalent to longer-term bicalutamide. And nodal radiation with hormonal therapy improves survival further. Several trick answers here. So, you're absolutely right. 2 years of androgen therapy reduces the rate of distant metastasis. A randomized trial has shown that. 5 years of bicalutamide, I mean, 5 years maybe, it's only 2 years of bicalutamide is what we used. 5 years, that sort of takes you back to the tamoxifen trials in breast cancer. 6 months of Lupron is not associated with high rates of gynecomastia. 6 months of Lupron is probably equivalent to longer-term bicalutamide, but the randomized trials haven't shown that because it hasn't been tested side by side. And that, I think, is that for this section. Thank you.
Okay, give us just a moment here while we get things set up for the next one.
Okay, my last talk of the day, I'll try to make this reasonably quick. It's just basically an overview of cervical cancer, and my disclosures haven't changed in the last hour. To me, this is a passion of mine because there's over 500,000 new cases worldwide of cervical cancer every year. It is the second most common cancer in the developing world. It is an AIDS-defining illness. There was only about 10,500 new cases in the US, but worldwide, we wrote an article recently about cervical cancer. It is a global health crisis. It's like a 747 crashing every day, and we just ignore these women. And it's usually younger women too. So I think that we have to do a better job of treating, preventing, and diagnosing. And as you know, from a treatment standpoint, the vast majority of cervical cancers are HPV infections. Most are transient infections, and they develop and they go away, but they can develop into CIN 1, 2, 3, and progress to cancer. About 90% are cleared without progression and regress. The cofactors for persistence of the HPV infection include smoking, increasing age, HPV types, which we'll discuss, mutagens, immunosuppression, inflammation, hormones, and some genetic factors. And as you know, the high-risk types are types 16 and 18. It's responsible for 70% of the cervical cancers. 31 and 45 tend to be responsible for 10%, and then there's a vast array of other HPV subtypes. The low risk are the genital wart types, which are 6 and 11. And we all know HPV vaccination saves lives. But in 2015, HPV vaccination coverage with greater than or one dose in adolescents was only about 50%. The recommendation is routine HPV vaccination starting 11 to 12 is approved for males and females aged 9 through 45. Less than 15-year-olds is 2 doses, greater than 15-year-olds is 3 doses. Immunocompromised patients require 3 vaccines regardless of age. Gardasil 9 is the only HPV vaccine distributed in the US. It does HPV type 16, 18, 31, 33, 45, 52, and 58. That'll be an ARS question. No, it won't. Sorry. I'm trying. You're a tough crowd. And it's about 80% of cervix cancer in the US. Not all of them, but 80%. So what our screening guidelines will go as we increase the patients that are HPV vaccinated will be interesting. So pap smears are still required at regular intervals. I was just on a call a couple days ago. There is more and more evidence that a single dose is efficacious. And throughout the world, there's going to be a real try to get single doses of HPV vaccination in developing worlds to try to prevent this horrible tragedy. The United States the use SPTF 2012 pap smear guidelines are under 21 years old, no testing, 21 to 30, pap every 3 years, 30 to 65, pap every 3 years, or a pap and HPV testing every 5 years. I have a little bit of an issue with this. I'm not sure that we need to do pap smears every year, but I think a pelvic exam should be a part of a woman's physical. So I tell patients that they don't correlate the two. Maybe we can get away with less pap smears, but probably should still get a yearly pelvic exam. I think they're two separate issues. Histological type, the mass majority of cervical cancer are squamous cells, followed by adenocarcinomas. Clear cells, I've used to see a few with DES exposure, but now as those women get older, that's going even down farther. And then there's other more rare sarcoma, lymphoma, neuroendocrine, or so-called small cell carcinomas. This is mostly going to be about squamous and adenocarcinomas. For staging and workup, the FIGO staging system was changed again in 2009 to do 2A1 and 2A2, which is less than 4 centimeters or greater than 4 centimeters. So again, stage 1 is confined to the cervix. Stage 2 is either upper vaginal or perimetrial involvement. Stage 3 is sidewall or hydronephrosis or distant vagina, and stage 4 is bladder and rectal involvement. Again, it's a clinical staging system. I will tell you, I don't know if other gyne treaters here like Kate and Mark know, but the FIGO is probably going to change it. And I've been trying to argue for a radiographic staging system in the developing world, because obviously pelvic lymph nodes makes a big difference. And they might come up with a little bit more complicated, but a system where we can incorporate them into our staging system, because pure clinical doesn't necessarily tell all the story, at least in the developed world. Again, pelvic exam under anesthesia. I don't do that very often, but we do it when it's difficult in the office to get a good exam. Cystoscopy and proctoscopy only if you suspect involvement. I don't think most of us do this routinely. Chest X-ray, I think, has been supplanted by more aggressive imaging, which we'll talk about. This is in the staging system, which I do think needs to be changed. I haven't done an IVP in 27 years. I haven't done a skeletal survey, so I'm not sure this is really what we should do. So FIGO clinical staging, which is not allowed, but obviously we continue to talk about, is CT scan, MRI, PET CT, and exploratory surgery, which we'll talk about. The patterns of spread, as you know, spreads parametrial lymph node, obturator lymph node, external, common, and periodic. Tends to spread fairly systematically, meaning it's unusual to have isolated periodic nodal disease, but it's not unheard of. And the risk of lymph node metastases, if it's stage 1A1, is less than 1%. But even with 1A2, it's 6 to 7% per pelvic and less than 3% per periodic. And this is, I know there's nobody, at least looking at the crowd, I don't think anyone's going to be taking their boards here, but it's 15, 30, 40, 45 for 1B, 2B, and 3. Pretty easy to remember. And about half of that to 2/3 of it for periodic nodes, 10, 20, and 30. So really one of the take-home lessons for treating cervical cancer is certainly if there's a positive pelvic lymph node, you got to think long and hard about whether you're going to treat the extended field. I think we threw away extended field a lot with R2G9001, and I still treat a fair amount of prophylactic extended field. So determining the extent of primary tumor, pelvic examination is not great. It's only about 47%. MRI versus CT, the staging accuracy is about 86%. MRI is superior to CT in detecting uterine boundary involvement and parametrial invasion, and MRI is superior in detecting vaginal extension. And we'll talk a little bit. We did an NCI consensus statement about a decade ago about what imaging we would recommend in the developed world. In determining the primary disease, using a vaginal gel in the vagina is very useful in determining the extent of disease. I very routinely do. We have a so-called cervix protocol, which includes vaginal gel for our MRIs. And then determining the extent of lymph node and distant metastases is PET scans really very useful. I generally get a PET scan on everybody. And this is some data from JCO with Kids article looking at disease-specific survival related to pelvic PET scan nodal status. And if you've had none, the survival was better. It goes down when the PET scan was positive in the pelvis, down in periodic, and down with supraclav. So it's pretty predictive of outcome depending on what the PET scan showed. And again, this is disease for stage 2 and stage 3 showing a decrement in disease-specific survival depending on the PET scan data. I find it interesting that in stage 2, none versus pelvic was similar. What I would say for staging, what do I do for staging? If I'm treating somebody definitively, I do obviously an exam. I get an MRI of the abdomen, pelvis, and a PET CT, if I can get it. Sometimes that's a little bit of an argument, but the MRI does the same for lymph node and gives you better soft tissue delineation. I think CT, chest, abdomen, pelvis, fine. I just can't see the soft tissue delineation quite as well. So the overall strategy for treatment, pretty straightforward. For stage 1A1, which is small tumors, hysterectomy, cone bias, radical trachelectomy are all options. For 1A2, 1B, radical hysterectomy or radical trachelectomy, and for all other patients, probably should get radiation, because I think the standard is to try not to do both modalities. And this is something to remember. There are different types of hysterectomies, and it's important to know which type when you're trying to tell people if they need radiation after a hysterectomy. There's a supracervical hysterectomy. If anyone does that for cervical cancer, that would seem kind of unusual. There is certainly a total hysterectomy, which, just to keep it simple, just takes out the cervix and uterus, which again is not, is for early stage cervical cancer may be an option. There's actually a randomized trial going on looking at, for less than 2 centimeter disease, simple hysterectomy versus radical hysterectomy. But it's probably not the standard. The standard is some form of radical, which simply means taking out parametrium and a little bit of the upper vagina. That's all you really have to remember, is whatever kind of radical you talk about it. So these are kind of the types of hysterectomies, which I think is important when you're deciding adjuvant treatment. Again, extrafascial or simple hysterectomy takes almost no vagina. They partially mobilize the bladder. The ureter is not mobilized. They cut at the uterine artery, minimal parametrium, and the uterosacral ligament is not taken. So this is a simple hysterectomy. So a lot of the areas we worry about in cervical cancer are not removed. Modified radical is upper, which is probably the most common treatment, is upper 1 to 2 centimeters of vagina. They partially mobilize the bladder. They unroof the ureter in the parametrial tunnel. They cut at the medial to the ureter, parametrium medial to the ureter, and the ureterosacral ligaments at the midpoint. So again, just a wider margin, gives you more information about extra cervical spread. And then radical, upper 1/3 to 1/2 of the vagina, completely mobilized bladder, dissected entry into the bladder at the origin of the urinary artery, at the sidewall, and at the distal attachment. I don't know many people that do that in the developed world. Much more common operation in the developing world where there's no radiation or chemotherapy. Extended radical and partial exoneration, as we know what those are. So the treatment for stage 1B, radical hysterectomy and pelvic plus minus aortic lymph node dissection or radiotherapy. I think either one are legitimate. I think radiotherapy is better. Wonder why. The dose we'll talk a little bit about. We are actually participating in BRACE 2, which might be the most difficult, complicated protocol we've done for no reimbursement. And they're really trying to push the doses a little bit higher with image-guided brachytherapy. We'll talk about that more tomorrow. But this is a classic paper that everyone probably has seen. It's from Landoni and Lancet in 1997. It was a randomized study of stage 1B to 2A cervical cancer between classic radical surgery, which was a class 3 radical hysterectomy, or RT followed by brachytherapy. And then anybody who had significant risk factors for recurrence in the surgery arm got adjuvant radiation. The median follow-up was 87 months. There was no difference in survival or local control, but 64% of the patients in the surgery arm ended up having adjuvant radiation. So it wasn't really surgery versus radiation. It was kind of like prostate cancer. It was mostly surgery and radiation. There was higher rates of urological complications with combined surgery and adjuvant radiation. So I think most of us go by the credo, if you think you're going to need postoperative radiation, you should probably just do radiation as a treatment. So what is the role of adjuvant radiotherapy? GOG 92 was a randomized trial of lymph node negative high-risk patients, 277 patients, stage 1B, radical hysterectomy and lymph node dissection, and we'll talk about the so-called Sedlis criteria in 2 seconds. And it was randomization between radiation or no further treatment. Simple trial. And this is, I always have to kind of look this up because it's a little bit more complicated than you think. This is the eligibility for GOG 92. You needed 2 of 3 factors to be considered eligible. So capillary lymph space invasion and stromal invasion, tumor size were all put together to make the risk factors that went into the trial. So if you had a small tumor, you needed deep invasion, unless you had a positive capillary space invasion. So capillary space invasion is positive, deep invasion, any tumor size. And you can go through this, greater than 2 centimeters, greater than 5 centimeters, greater than 4 centimeters. So it's a little bit more complicated, so I really have to go back and look at it when I'm trying to decide if the patient truly fits this. I could tell you I do not have it memorized. And this is the update which was published by Rotman in the Red Journal in 2006 with a median follow-up of 10 years. Progression-free survival, there was a 46% reduction in progression-free survival. Overall survival, there was a 30% improvement. The grade 3-4 toxicity was higher in the RT arm, but not too unreasonable, 6.6%. And the adenocarcinoma and adenosquamous recurrence rate were 8.8% in the RT versus 44% in the observation group. So our adenocarcinoma seemed to have even more benefit than the squamous cell carcinoma group, but certainly a positive trial and fits the criteria. I think the criteria, take it with a grain of salt. I've had residents say, we're not going to treat because it doesn't fit the Sedlis criteria. That was what was arbitrarily taught. If you have a tumor with extensive LVSI, I sometimes treat even if it's not in the Sedlis criteria. So I think this is not a cookbook. It's just something for an argument for the trial. What about chemotherapy, chemoradiation after hysterectomy? This is the classic trial, GOG 109, which looked at high-risk postoperative patients. It took 243 patients that had positive margins, positive lymph nodes, or positive parametrial invasion, and randomized between RT alone or RT plus chemotherapy. And the 4-year progression-free survival was 80% in the chemo-RT arm versus 63% in the RT alone arm. And 4-year overall survival was also improved, suggesting a benefit. There is a current randomized trial going on through GOG 263, which is looking at Sedlis criteria, chemo-RT versus RT alone. Ask me what I do in practice. Most of the time I give chemo-RT, unless it's really low risk if I'm giving adjuvant radiation, to be completely honest. How about locally advanced disease? This was a a classic table that looks at the relative risk of improvement by giving chemoradiation versus radiation alone when you're treating for locally advanced disease. This led to an NCI alert in 1999 suggesting to give chemoradiation. And this is a relative risk of survival between the 5 classic trials, or the 6 classic trials that were done. GOG 85, we'll talk about some of these, GOG 120, GOG 123, SWOG, and RTOG. And what were these? If you look at concurrent weekly cisplatin and RT, so GOG 120, again, these were published, the Keys article and the Rose article were both published back-to-back in the New England Journal of Medicine. And the Rose article was stage 2B to 4A, whole pelvic radiation, brachytherapy and hydroxyurea versus cis-5FU or weekly cis, and this was a preoperative therapy, and then they went to hysterectomy. Overall survival was improved, less toxicity with cis alone or hydroxyurea alone, although that didn't work as well. So this kind of suggested that cis worked just as well as cis-hydroxyurea with less toxicity. What I find interesting is that the only trial that looked at what we normally do in practice, it was negative. Go figure. That's the NCIC PIRC trial, which looked at 1A to 2A greater than 5 centimeters or 2B disease, and it was simply whole pelvic radiation and brachytherapy versus the same treatment with weekly cisplatin, which is what most of us do at 40 milligrams per meter squared, and there was no difference in outcomes. The Keys trial was 1B2, whole pelvic brachytherapy plus surgery versus weekly cisplatin plus surgery, 74% versus 83%, and again, increase complete response with chemotherapy. Probably the classic, the classic for our RTOG was RTOG 9001. It built on RTOG 7920, which was a randomized trial. If you remember, I didn't include this. We looked at extended field radiation versus pelvic radiation, and it was positive for extended field radiation. This trial looked at extended field radiation versus pelvic radiation with chemo. It showed that it was whole pelvic radiation plus brachytherapy versus cis-5FU, a significant improved overall survival and reduction in local controls. There was some increased risk of periodontal failures in the chemo RT arm. It was 9%. So I would tell you that I still, every time I see a patient, think about whether to do extended field radiation. We did do a trial that I didn't include in this, RTOG 0116, which was my trial where we did extended field and chemo with amifostine to try to reduce toxicity. Didn't really help, and it was still pretty toxic. But in the era of IMRT, I think we can get away with extended field a little bit more. Something to always think about. And that's where we talked about that data where 15% false negative rate with PET scanning when you did a lymph node dissection in the periortic area. So it's something I consider on every patient, especially if they have pelvic lymph nodes involved. SWOG 8797, which was stage 1, 2, or 2A post-hysterectomy, gave whole pelvic radiation plus cis-5FU times 4 cycles. Noted an improvement, and so did GOG 85. So there was a meta-analysis of 15 randomized trials of chemotherapy and radiation versus radiation alone. It included 3,452 patients. This was, I think, a well-done randomized trial. It was published in the JCO. And there was an 8% absolute improvement in disease-free survival across all these trials. The overall survival benefit was 6%. The 2 trials that looked at chemo-RT and further chemo versus RT alone showed a 19% overall survival rate. So there is some data. It's not a huge improvement, but there is an improvement. I think it is completely standard of care. So with that suggestion that giving more chemo may be better, should we be given adjuvant chemotherapy in advanced cervical cancer? This was a randomized trial published in the JCO in 2011 with 515 patients, chemo-RT and brachytherapy versus chemo-RT and Outback cis and gem for 2 cycles. And the use of the cisplatin and gemcitabine improved progression-free survival from 74% versus 65%. There was an improvement in overall survival, but the toxicities were pretty great. There was more serious grade 3-4 toxicities. There was 30% hospitalization rate. So it was a pretty toxic regimen, and I don't think has been adapted very often worldwide. It did lead, though, it did help to lead to this study, which I'm one of the co-chairs of, which is Outback chemotherapy. So it's stage 1B2, 2, 3B, or 4A cervical cancer. It's a combination of Ansgar, RTOG, GOG trial radiation, we usually do chemo-RT with brachytherapy versus chemo-RT with Outback Carbo and Plasitaxel times 4 cycles. This is actually not a bad thing. It's not Protect and doesn't talk about hooligans in soccer, but it's Outback chemotherapy run by the Australians. I thought that was pretty good. And it is, what's good and bad about it, it's been closed for a couple years. There's a lot less events than we predicted, which is great on both arms. In fact, it was extended to almost 1,000 patients to be accrued to try to get some data, but it'll have to be reported at some point because recurrences generally happen within the first 2 years. But so far, there's been good data on it. So what's the general treatment strategy for locally advanced disease, stage 1B2 to 4A? External beam radiation, 45 gray. I think that I was a relatively late adapter of IMRT for intact cervix. I really just started doing it routinely in the last couple years. I think that there's some data from Lauren Mel's group, and now that we have image IGRT, I'm not IGRT, but image-guided radiation therapy. Now that we can do daily cone beams, I'm much more okay with it. So I've really started to switch to IMRT. I do a boost of the parametrium. My standard treatment, and this is technically what I do, is first do obviously the external beam radiation with 40 milligrams per meter squared daily of at least to the bifurcation of the aorta. I've made that mistake before. Back when we were looking at bony anatomy, I had 2 or 3 recurrences right above my field when I put L4, L5 as the edge of the field. And looking back on the CTs, I just didn't. There's a node that sits right between the bifurcation and the aorta that sometimes is involved. And I've always now go to the total common iliacs and treat from the bifurcation down in any patient with cervical cancer that I'm giving radiation to. What my big thought is whether I do a slightly extended field. It's not that extended to the renal vessels to treat the low periortics. That ends up being not that much more. So if there's disease in the pelvis, I strongly consider it, even if the PET scan's negative, unless we did surgical staging, which at our institution we rarely do. And then followed by brachytherapy. Brachytherapy, we'll talk a lot about techniques tomorrow. You can do it all sorts of different ways. I typically do it the way the Vienna group does it, which means that I treat all 45 gray, and the Monday after the chemo-RT, I do the first implant, and I do 2 doses and do an MRI for the treatment. So I do the implant in the morning, get an MRI, give image-guided brachytherapy in the afternoon, have the patient stay overnight, give a second dose, do that twice, separated by 1 to 2 weeks, and give at least, I try to get the HRCTV to about 90, but we'll talk about that tomorrow. And then give concurrent chemotherapy at 40 milligrams per meter squared. So doing the PET scan and MRI simulation, this is a PET scan simulation. I don't think you need to simulate with the PET unless someone wants to donate some money. I'd love to have a PET scan in our department, but certainly should use it in your designing your radiation fields. And I'd also like to have an MRI simulation if someone's got some money too. I simply fuse the images and try to get the images onto the planning system. This is your classic RT fields, 4 fields. Typical things to remember is that I think it's important probably to treat to the bifurcation of the common iliacs or above the bifurcation of the low periortics. Make sure you're wide enough on the obturators and think about the uterosacral ligaments. They tend to go a little bit lower than you think on the classic previous fields, but this is kind of a classic 4 field. The controversies for intact cervix is the same controversies that we talked about for post-op. Contouring, what do you need to contour, what is the organ motion, the simulation set up in IGRT, same problems as post-op. So we did publish a consensus guideline for delineation clinical target volume for IMRT for definitive cervical cancer. It is talking about what the areas you need to contour, the parametrium, the upper vagina, the gross disease, the uterus, and then obviously the organs at risk. I think it's a reasonable thing to consider. We've talked a lot about nodal contouring, or we did talk a fair amount about nodal contouring in the previous session. Just make sure you're covering the nodes and the obturator nodes. I think probably the obturator canal is probably the area that people miss the most. Remember to contour the obturator canal. I've seen multiple recurrences in that area. CTV tends to include the entire uterus and cervix and the bilateral parametria bilaterally. And I still include the entire uterus, but not in the IGRT field. I mean, not in the brachytherapy treatment, but most of us still include in the CTV. Inferiorly to the upper border, the obturator framer of no vaginal involvement or 3 centimeters below the gross disease is the CTV for the cervix and uterus. So entire uterus, cervix, upper vagina. And again, this is just combining it with the obturator nodes, and that's some of the motion that can happen. So thinking about the motion, it sometimes goes posterior. So one of the arguments is you're really not gaining that much by doing IMRT. So I think that if you're not comfortable with it, I think forefield is fine because the uterus pushes most of the bowel out of the way. So I don't think there's a right answer to this, although you just have to be careful what you're treating. Again, this is an example of a full empty bladder and then combined. So just some of the motion, the uterus can move dramatically between a full and an empty bladder. So if you're going to do IMRT, whether you do an ITV or not, the same issues come in with PTV and organ motion, and just make sure you watch the organ motion between the treatments. This is a patient this is between 2 different treatments. This is the uterus. When the bladder was full and empty, it's almost completely out of the field. So I think that if you're doing IMRT for cervix, really understanding the cervical motion and how you're going to address that is incredibly important. And this is a bunch of articles that look at interfaction cervical motion. I won't go into details, but some of these movements are 2 to 3 centimeters in between treatments. So again, if you're doing IMRT or something fancy for cervical cancer, just keep that in mind. And the methods, we're actually putting seeds in the cervix so you can watch the cervix move. And again, you can't really move to the seeds because of the nodal volumes if you're doing IMRT, so you can't move the field every day. And again, other ways that people were doing things. The max motion, the AP dimension ranged from 18 to almost 6 centimeters when the uterus flipped back and forth, and the max motion superior to inferior was 2 to 4 centimeters. So this is moving a lot. So again, if you're doing something fancy in intact cervix, make sure you're adjusting for this motion. Movements, AP, superior and inferior. And again, the max motion, when you look at these different things, are 3 to 4 centimeters or 2 to 5 centimeters in the AP dimension. So again, I'm not saying it's not wrong to do IMRT for intact cervix. I've actually started to do it more often nowadays, but really got to watch for the cervical movements, even worse than in post-op because the uterus itself can be moving. Just a case report. This is a 45-year-old with 1B2 cervical cancer, treated with initial CT SIM and fraction 1 with cone beam CT. And this is fraction 4. Same patient. Again, the uterus can move dramatically, so if you're using something fancy, just be careful with what you're looking at. And again, same thing. This is another patient who, there's a lot of data on when you tell patients to fill their bladder. Some fill it, something is full when it's empty, something is empty when it's full. This is a patient with initial CT SIM, fraction 4, cone beam CT, obviously the entire target volume's out of the way, out of the field. If you were doing forefield for this, it'd be in the field. So that's why if you're going to adopt something more fancy, just be careful about where you put the fields. And again, that's going out. So considerations, same as we talked about for post-op. I do like doing a full and empty bladder. I do like getting an MRI and use all your available imaging for contouring your ITV. There's different options out there. The Intertech trial that Lauren did has different PTVs depending on what you're looking at, whether it's a cervix or whether it's a nodes. CTV to PTV margins for primary should probably be at least 1.5 to 2 centimeters. ITV to PTV margins can be less because you've tried to account for some of the motion. And CTV to PT margins for nodals probably only 7 millimeters is probably okay. So I think this is kind of what I use, is I use an ITV in 7 millimeters as my typical volumes. And then I do think I do get daily soft tissue IGRT if we're doing IMRT in a intact cervix, because I've seen some weird motion that can happen, and it's relatively easy to see it going out of the field. But it probably is, you probably should do IMRT if you're treating the paraortic nodes. I think it really does offer an advantage. So sometimes I'm almost always treat with IMRT if we're treating an extended field. And sometimes the PTV looks like a forefield pelvis in the pelvis. I think that's okay. It's also, I think, important if you're treating the inguinal nodes because of distal vaginal involvement. That's hard to not treat without using IMRT, so I do that routinely. And boost, I do the IMRT for nodal boost or sidewall boost. So I typically, I wrote another editorial in Gyne-Onc last year about this. I think I typically take nodes a lot higher than people have said they take them. So my nodal dose for a gross nodal disease is at least 65 gray. Now you have to be careful about that. You should include the brachytherapy dose. You should watch your organs at risk, but what is the salvage rate for an uncontrolled lymph node in the pelvis from cervical cancer? Essentially 0. So it's, it's a painful, awful death when you watch someone die a sidewall death. So I do take a little bit more risk than some people would say. In my R2G0116, we did not mandate nodal boosts, and the range of doses we gave was between up to 5940, and that was the most prominent cause of recurrences, was nodal recurrences. In my own data, I haven't seen many nodal recurrences if I've treated them correctly. So I would say you should take gross nodes to whatever dose you're comfortable with, but they probably should be boosted higher than 45 to 50. So what about the periodic nodal metastases? What we talked about, this is not uncommon. From 1B, it's 5 to 8%, but when you get to 2B and 3, it's a fair amount of patients have periodic nodal disease. So what is the accuracy of PET-CT staging in the periodic nodes? This is what we've been talking about. So these are various articles that used surgical staging. The positive periodic rates were anywhere from 10 to 25%, so it's a not uncommon disease. The positive predictive values of PET-CT were ranging between 50 and 75%. The negative predictive values were between 83 and 92%. So it's not perfect. So there are going to be nodes in that area that aren't picked up by PET scans. If you total them all up, 664 patients in these various trials, the positive periodic percentage was 13%. Positive predictive value was 50 to 75%. The negative predictive value was 83 to 92%. So I think this is something that you have to really think about when you're treating patients with cervical cancer. Just like we talked about, a negative image doesn't mean there's not disease there. So I actually have a very thoughtful conversation with the patient. If there is common iliacs, especially high common iliacs, I think everyone treats. But even with the pelvic lymph nodes, I've seen some problems. And this is that story we talked about. This is 421 patients with stage 1B to 2 disease who had complete infrahilar lymphadenectomy. Overall, 26% of the patients had positive lymph nodes. 26 with positive pelvic lymph nodes had positive periodic lymph nodes, and 40% had no macroscopic pelvic lymph nodes. So you even can see that without macroscopic pelvic lymph nodes. So we've gotten that trial denied a bunch of times. I think a good trial would have been taking 9001 treatments between prophylactic versus pelvic only with chemo in both arms, but I don't think it'll ever be done. And this is a nodal anatomy. I could tell my age too, because I used to get a lot of lymphangiograms before there was PET scans, and that might have been the most torturous thing we've ever did to patients, because it was a cut down on the dorsum of the foot and an injection, but I could actually see the nodes, so I thought it was really cool. And this is where the nodes tend to sit. There's a lot of data on this. And this is the role of surgical staging versus clinical staging, randomized trial, FIGO stage 2B to 4A cervical cancer. Arm 1 is cervical staging, pelvic periodic lymph node dissection. Positive periodic nodes get extended field, negative get pelvic RT. Arm 2 is clinical staging, positive periodic extended field, negative get pelvic chemo RT. This will actually tell us how often this negative predictive value means and what we really should be doing in the clinic. Arm 1 was surgical staging, 125 patients, 23% had positive periodic nodes. In the clinical staging, in the biopsy of a sebaceous lymph node, it was 12%. And these were the nodal failure rates. 80 nodal failure rates, 78% of them were in the periodic nodes in the clinical staging. Again, suggesting that imaging alone is not necessarily a great predictor of whether there's periodic disease. Risk factors for periodic nodal dissection were common iliac or 3 or more positive nodes. So I just think you got to keep this in mind when you're treating cervical cancer. You don't just treat just because you see it. You have to think about whether to do an extended field. And again, this is one of the things Embrace 2 is doing. Embrace 2 is bringing into account some risk stratification for volume. And like I said, it's taken us like a year to get this open. They have low risk, what they define as tumor size less than 4 centimeters and stage 1A, 1B, 2A1, and N0, squamous cell carcinoma, and no uterine invasion, get a so-called small pelvic field, which includes the internal iliacs, external iliacs, obturators, and presacrals, but not the common iliacs. Intermediate risk, which is not low risk or not high risk, gets quote-unquote a large pelvis, which is a small pelvis with common iliacs. And of course, inguinal lymph nodes if there's distal vaginal involvement. Mesorasal space if there's mesorectal nodes and advanced local disease. So it's trying to kind of tailor your radiation to the cervical disease. And then high risk based on nodal path, greater than one pathological node or a common iliac or above or greater than 3 pathological nodes, just what we talked about. Some of the more high risk features for periaortic nodes get a large pelvis plus periaortic radiation, again to the renal hilum. And this will be in our next atlas, but what I point to, if I can get this to work, is that, this isn't much difference between intermediate and high. When you're treating to the common iliacs, it's only a few centimeters more. So it's not like it's a big periaortic chain. It's a little bit more if you treat to the common iliacs, which I tend to do. I tend to do even in low risk, but that's just what I do. And again, this is the high risk get extended fields. These are the field borders. The standard is L3, L4, which is only including external and internal iliac nodes, and then L2 for the common iliacs. But I think we should get away completely from bony landmarks. Every patient's a little bit different, but this just gives you a guideline of where the field borders would be. This is a little bit about the contouring the periaortic nodes, where they sit, where the recurrences happen. But usually in the aortocaval space is about 40%, about 50% on the left periaortics, and the right cable is about 4%. And hopefully, if we ever get the atlas done, we talk a fair amount about where these nodes sit when you are contouring the periaortic region. And this is talked a lot about. This is not a valvular case, but this contouring the inguinal nodes, how much margin is necessary. Kim published, we published. These happen fairly immediately. So the margin of the nearest femoral vessel required to encompass 90% of the positive nodes in this publication in 2012. Anterior medially was 3.5 centimeters. Anterior was 23 millimeters. Anterior lateral 25. Medial 22. Posterior 9. Lateral 32. That doesn't. I'm going through that quickly, but you just need to be generous if you're treating the inguinal nodes, especially medially. A lot of the nodes sit fairly medial. So key points. Concurrent chemo-RT remains a standard of care for locally advanced cervical cancer. IMRT may be appropriate in selected situations where careful contouring of the cervix and uterine motion and watching that on an IGRT basis. And I think prophylactic PART is based on pelvic nodal burden. I think that's one take home I really want people to remember is that don't just say I'm not treating because there's no periaortic. Think about the burden of disease in the pelvis and make that decision. Any questions?
Sorry, you might have said this, but so when you're using IMRT and you're treating the periaortics, you said you're trying to get away from bony landmarks. So the top border, what anatomic landmark are you using?
The renal hilums.
So the renal hilum,
yeah.
That's what you're using, okay.
Bill, you showed the PET data that shows a negative predictive value of about 90%
right.
in the periaortics. So help me understand why you would do elective periaortic radiation in a PET negative patient where the negative predictive value is so high.
I think that negative predictive value includes a lot of patients without pelvic nodes, so I think the negative predictive value would be less in higher risk patients. So I have this discussion. If it's 9%, we'll drop it down to 4 or 5% with radiation. So I agree but it's adding this much treatment, and I don't think it adds 4 to 5 complications. So I don't think there's a right answer, but that's why I do it in high risk patients. We want to hear Anthony's bad talks from. Yeah, any other questions? Sorry. Okay, question 1. The HPV types most commonly associated with cervical cancer are 16 and 18, 16 and 17, 17 and 18, or 19 and 20. And thanks again for Jim saying 19 and 20. Okay, sorry. The most accurate statement regarding the use of PET scan and staging of cervical cancer is hypermetabolic adenopathy is associated with reduced disease-specific survival. PET has no role in staging of cervical cancer. Prognostic use of PET in cervical cancer is determined distant mets not to identify nodal disease, and PET scan in cervical cancer is only indicated for assessment of response, not for workup. Uh-oh.
See if it works.
Okay.
Might have to reset it. Well, it's counting down. I'm just not sure if it's collecting. We'll find out in a second. Stand by. Yeah, it didn't collect anything.
Technology is great when it works, right? Fortunately, with this response system, we can afford to provide a lot of SAM credits that we just can't do physically without doing the automatic collection. But hopefully this will work this time.
There we go. It's collecting.
That's the number collecting?
Yep.
Yay.
Did it show it ahead of time?
I don't know.
Okay.
Radical hysterectomy differs from simple hysterectomy by removing perimetrium, cervix, more of the upper vagina, or answers 1 and 3. So it's, when you do ABR boards, they would not like 100% right, but I do. And again, knowing the type of hysterectomy, we didn't talk too much about it. I probably should have put a slide or two in. But if you have a cervical cancer treated with a simple hysterectomy, unless it's very low risk disease, most people would give adjuvant radiation. In the randomized trial of surgery versus radiation for stage 1B to 2A cervical cancer reported by Landoni, the primary conclusion was no difference in overall survival, increased toxicity in the surgery arm, surgery was associated with improved outcomes, or 1 and 2. I think it points to, you can put that in. It just points to that there's more toxicity when you combine the two, so try to do just one thing. The randomized trial postoperative radiation versus observation cervical cancer reported by Sedlis et al. Used all the following prognostic factors except tumor size, LVSI, grade, and depth of stromal invasion. Oh, it didn't use grade. Sorry if I didn't say that hard enough. It used depth of stromal evasion, LVSI, and size. All right, thank you.
Hello. All right. As we're well ahead of schedule, we're going to give you a little bonus talk. And I've already made an executive decision. I was trying to decide whether to appeal to your better angels or your worst demons, whether it was going to be scientific misbehavior or art and radiation. I've made an executive decision. It's going to be art. It's going to be art. But I'll tell you all about the misbehavior on another occasion, I promise. So, as many of you are aware, I'm the editor of the Red Journal. I have been since 2011. And when I took over the Red Journal, I'd long looked at my wife's copies of JAMA. She's an internist. And they always used to have art on the cover of JAMA, usually pretty fabulous art from the great museums. And I'd always thought we could do something similar with the Red Journal. JAMA, needless to say, did focus groups, and then they decided that actually they weren't going to have art on the cover. They were going to put it inside. What people really wanted was a table of contents on the cover. Well, I didn't quite believe that. So when I inherited the Red Journal, the covers were either red, or they had illustrations from, the brightest colored illustration from some article inside the journal that month. But I thought we could go better, and we could go better by, we don't have the money to buy art from, or reproductions of art from great museums. But I thought with 10,000 radiation oncologists around the world, and about an equal number of, no, more, physicists, dosimetrists, therapists, and nurses, there must be some artistic talent out there. So I put out an appeal and set up an art team. This was me, Catherine Bennett, who was then the managing editor of the Red Journal, and two of my associate editors, Jen Bellin, who's in Boston, and Pauline Trong, who's in Vancouver. And we were surprised at the extraordinary number of pieces of art that came in for our consideration. So what I've done is I mean, many of you will have seen them every month on the cover, but I've actually picked out some of my favorites, and I put them into little groups, because it's kind of fun to see them this way. The whole idea was that it would show the human side of radiation oncology. You know, it's not just our science, but who we are and what we do in our lives other than practice radiation oncology. So we've had a lot of sort of inspirational nature, either photographs or paintings. Now, this is a very common theme. Probably a third of the images that come our way reflect nature. And some of you may know Bernie Lewinsky, father of Monica, I might add, but his practice in Beverly Hills, California, is absolutely gorgeous. You would not know that you're in a radiation oncology practice, because he's a superb landscape photographer, and his pictures adorn the walls. And these are just two of the covers that he's had over the last 8 years. I mean, he goes into secret spaces. So this is an area of desert in Arizona that's actually military only. He somehow, I think once a year, they let people in to come and take photographs. So that was one of his pictures. And on the far side is a picture of a waterfall in Yosemite National Park, taken at night with a long-term exposure. And actually in the real picture you can see the stars twinkling. But what you can see is a rainbow. It's actually called a moonbow in colors in the spray at the bottom of the rainfall. So Bernie Lewinsky has been a very prolific contributor to the Red Journal. He really does some wonderful work. But it's not just photography. We've had a lot of paintings, and these are two images of trees, one from Pauline Trong, this is an oil painting, and Myra Keys, who has the office next door to her in Vancouver. So what is clear to me is that if you're in Vancouver, there's kind of not much else to do other than paint trees. I guess you could ski. You either ski or you paint trees. And actually, this is true because the next office along is occupied by Juanita Crook, who's a GU radiation oncologist. And this is not a photograph. This is a gorgeous painting that she did of leaves in a forest. That's just the Vancouver theme. And Jen Bellin herself is a very celebrated wildlife photographer. And some of her work's actually in the Smithsonian. And she takes these absolutely extraordinary pictures of the usually wild animals, often birds. She'll goes on vacation. She'll go to, Zimbabwe for 2 weeks, and for all of those 2 weeks, she will be lying on the floor, on the ground, waiting for one shot of an elephant walking past. She spent hours watching these giraffe, and there was a moment when an oxpecker just came down to sit on the giraffe's nose. These are extraordinary pictures. There are many others that she's taken. I could have her photography and Bernie Lewinsky's photography on the cover of the Red Journal forever. But it's not just faculty. Residents submit as well. This is a resident, Trevor Royce, is at UNC now. A nice picture of horses in Ecuador. And then this, you could take this at first blush as a picture of dawn, beautiful blues. It's a very nice image. But actually, you'll notice it's been submitted by Kevin Moore, a physicist from UCSD, San Diego. And actually, if you look, the title of this piece of this photograph is Dawn Patrol. And if any of you had any sort of preconceptions about what it's like to live in Southern California, that you will go surfing perhaps before you go to work, well, this fulfills them. This is the Department of Radiation Oncology, physicists and faculty, all going surfing before work one morning. They apparently do this once a week. That does not happen in Boston, let me tell you. And there are some fascinating sort of tales of, of healing that have come through the cover art. This was an extraordinary story. So I received first I'll go back. I received about 12 manuscripts from somebody whose name I didn't recognize, who's at a university in central India. He was a resident. And they were pretty sort of low-par science, and we rejected them one after another. And then he started submitting letters, which didn't really add very much. We rejected those as well. Then I received a letter directly from him to me. Dear Dr. Zeitman, my name is Swaroop, and I've submitted a lot of manuscripts, they've been rejected, letters, they've been rejected. I want you to know that I'm very idealistic. I really want the best for our field, but I'm becoming dispirited. And the final line was very chilling. The pills are no longer working. So I began to think, oh my God, I've got a suicide risk on my hand. This is somebody who's in central India. I don't know. What do I do? So, in this day and age, I called up his chair in central India, and I said, I'm very troubled that one of your senior residents, who seems to be writing a lot, sent me this disturbing letter. And they said, well, yeah, he was getting very depressed. He's left. I said, where did he go? They said, we don't know. But he's a very good landscape photographer. We think he's gone up into the Himalayas to find himself. So I sent an email out into ether space to this guy, if you're around, I've thought of one way you may get published in the Red Journal. I have heard that you're a landscape photographer. I heard nothing for 3 months. And then all of a sudden I had 5 pictures from him. And they're all very grey and quite dark. They're lowering skies. This is an abandoned Tibetan monastery. But they were magnificent pictures. And we accepted one, so he has been published in the Red Journal. He's gone back, he's completed his residency. He's now on faculty. And he's now my mole in India. So we've had quite a lot of trouble with fabricated papers, fabricated data. And he gives me a lot of inside information. So he's turned out to be a really huge asset. This is another extraordinary one. I went to visit Fukushima in Japan. Fukushima, where they had the nuclear meltdown, the earthquake, the tsunami, the nuclear meltdown, the big radiation cloud. And I was being shown around, and I just noticed that one of the faculty had this sort of leather pouch around his shoulder and on his hip. And I thought, that's a beautiful pouch. It had this beautiful tooled leather. And this is the classic sort of iconic image, Japanese image, that he had actually tooled himself onto this bag, onto the leather, and made his own bag. And then I noticed that there were little tubes sticking out of the bag full of green fluid. So I thought, what is this? This is a beautiful bag. First of all, it turns out that he had a hepatoma, had a hepatectomy, a partial liver transplant from his brother. He's cured of his hepatoma, but he has nowhere to drain his bile. And he drains it into the bag. And he started leather crafting in order to design these bags to conceal his biliary drainage tubes. Oh, it was absolutely brilliant. And a lot of the images reflect culture. So we've had some fabulous art from Asia. Or from Asian Americans, in the very traditional classic Chinese style. The one on the right is, it actually hangs in my house at the moment. It was given to me by the head therapist in the major institution in Hong Kong I visited. And this other one, classic Chinese art in pen and ink. These are beautiful. And then I was at a meeting in London, and some small gent from Southeast Asia came rushing up to me with his cell phone out like this. And he's, no word of introduction, just flipping, flip, through images on this. I had no idea what he was asking me or showing me. And then it became clear he was showing me his own paintings. And he was wondering whether I would be interested. It turns out this guy who's called Arthur Mint, Sonny Mint, who's actually quite a senior figure in Liverpool in the UK. I'd never met him before. He had, as a young man, he was an artist in Burma. He was a revolutionary artist. He painted the kind of things that you weren't allowed to paint, like nudes. He painted nudes. And he and a group of revolutionary artists were actually drummed out of the country. He pitched up in England, went to medical school, and is now a radiation oncologist in Liverpool. And he paints these dreamy pictures of an imaginary Burma, the Burma that pushed him out. They're sort of fantastical pictures of, I mean, you can see there are towers and imaginary horses, and they all have this dreamy, hazy style. But it's a romantic memory of a Burma that he wasn't allowed to share. And we are an amazingly creative community. These are just three good examples, because it's not just art, and it's not just painting, it's not just photography we have on the cover. This is a piece of wire art done by Brandy Page. On the far right, Terry Wall, who some of you know from Kansas, is a sculptor. He sculpts in bronze, gigantic sculptures. So this is one of his that we featured on the cover. And then Mac Roach, who many of you will know or have heard of. Mac Roach is actually a fabulous artist. He said, Anthony, when I was visiting San Francisco, come to my studio. Come and have a look at my pictures. And I'm looking around, and I see all around. He says, you can have anything you like for the cover of the radio. I look around, nude, 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 nude. I can't find anything that isn't. But I found this one. It's a woodcut he did 20 years ago. So that is on the cover, because, we have limits. And again, it's more than just your usual. Stan Field, who's one of the great radiation biologists of the 1960s and 70s, when he retired, he took a ceramics course. And makes this beautiful Japanese-style pottery. This is a tea service. On the left, Jim Ollison, a physicist from North Carolina, makes beautiful furniture out of rare woods. I mean, really gorgeous. So it's nice to be able to feature this. Now, I'm going to tell you that this is a piece of art by Patty Eiffel, to stick with the gynecologic theme, from MD Anderson. It's not at all obvious what the piece of art is. Is it the painting? Did she paint the painting? Is it the wallpaper? What is it? Well, it turns out it's all her art. She makes dolls' houses. And she makes tiny miniature pieces of furniture for the dolls' houses. This is her art. It's absolutely staggering. She also happens to be the president of the Houston Photographic Society. I mean, she's a talented photographer as well. So we are really lucky to have these people within our specialty. Sometimes we use art to highlight major events in the specialty, or major events for the journal. So when a grand figure from our specialty dies, we often have an obituary, and we like to accompany it with some art, either art that they made themselves or by one of their mentees. Malcolm Bagshaw, who died a few years back, one of the great figures from Stanford, great figures in the prostate cancer world, was a watercolorist. And we put one of his watercolors on the cover. We had a special edition on radiation therapy in the elderly last year. And this painting was done by somebody called Michael Baum. Now, Michael Baum is not a radiation oncologist. So one of the conditions for the work going on the cover is usually that you've got to be a member of the radiation oncology team. That's the condition. Now, I made an exception for him for two reasons. Number one, he's a surgeon, but he's one of the great trialists. His big thing was breast cancer. He's done trials on tamoxifen. He did the earliest trials on tamoxifen back in the 1960s and 70s, recently on intraoperative radiation. I mean, he's a very significant figure in Britain. And because of all his contributions to oncology, he was made a Fellow of the Royal College of Radiologists, FRCR, by the radiation oncology community. So he's an honorary radiation oncologist. Good, I can put his art on the cover. He's now 80, and this is a picture of him with his grandson walking on Hampstead Heath in central London. It was a perfect fit for the elderly special edition. Now, this is another one case where I made an exception. In 1965, there was a classic conference in which it was demonstrated clearly that radiation improved the survival of patients with Hodgkin's and non-Hodgkin's lymphomas. It was the Paris conference. It was a landmark event. And 50 years later, there was a conference to celebrate that. And we needed a good cover. Now, as it happens, my father-in-law used to be an anatomist at Guy's Hospital. Guy's Hospital in London has an anatomic museum. And the curator of that museum from 1830 to 1835 was Thomas Hodgkin, he of Hodgkin's disease. So I actually, one way or another, was able to get the copyright and to print. This is a watercolor made of the wax models that Hodgkin used to make of his post-mortem dissections. So this is the first demonstration of the distribution of lymph nodes in a patient with what later became known as Hodgkin's disease. And as radiation oncology didn't exist at the specialty at that time, I've allowed his art onto the cover. He gets in by exemption. And I think we've had some art that is close to perfect. This I particularly love. I think the color is absolutely gorgeous. This is by Eva Katsoulakis from New York. And I used this cover to mark the point at which the Red Journal's editorial board became 50% women. So it's, that it is the future, and we wanted it to happen, and it did happen. It happened really remarkably quickly. And I didn't make a big noise about it, but we did mark it with this cover. And this is an absolutely gorgeous cover from that we published a few years back. And this is probably my favorite. You may or may not have heard of Professor Sir Michael Peckham. Well, Mike Peckham was the head of the Royal Marsden Hospital, its oncology department. In Britain, you're both a medical oncologist and radiation oncologist at the same time. That's how I was trained. So he's head of oncology at the Marsden through the 60s, 70s, into the 1980s. He was one of the first people, along with Larry Einhorn, to demonstrate the role of platinum in testicular cancers. He was one of the earliest people to use chemotherapy in lymphoma. You'll remember the old regimen British MOP. That was Mike Peckham's contribution. And all the while that he had this extraordinary career in oncology, which went on, he became the chief government advisor on science and health. All the while, he had a parallel career, equally glorious, in art. He was being exhibited at the Royal Academy. He could have chosen either career, but he had both, and he succeeded at both. It's really quite extraordinary. And this is a picture. He retired to Provence in France, and this is an oil painting, very typical of his abstracts, in which he represents the nightingale. Nightingales sing in the forests of Provence. So he's representing night, the purples represent night, and the lavender fields. These brightly colored squares are the cadence, the brilliant song of the nightingale. So it's, I just think it's a gorgeous piece of art. And if you actually go to the edition of the journal and look at his description of this piece, it's really wonderful. So it can also be a challenge to deal with this art. What do I mean? Well, first of all, you have to reject some of it. And it's bad enough rejecting people's papers, which I do all the time. That's wounding enough. But to reject somebody's art, woof, you just cut them through the heart. So we do it incredibly gently, but we do have to do it. And sometimes we have to reject art, not because it's not good art, but because for some reason it isn't appropriate for the cover. So this is, I actually thought this was very interesting. This guy, Finn von Iben, is an oncologist from Denmark. And he submitted this 4-piece sort of Hockney-style set of images that he painted of himself as a young man. And I thought this was fabulous. I thought, great, we'll stick this on the cover. And then my co-editor said, "Whoa, hang on, what's that in his mouth?" I don't think so. Oncology journal, smoking a pipe. So I had to say, "Oh, you're going to think me terribly censorious, but I'm saying, we can't accept this cover. Could you send me something else?" All right. So he sends me something else. Whoa! This is the time of, hashtag me too. So, woman, anonymous, face in the dark, naked, submissive position. I don't think so. That's not going to fly either. So I had to, you're going to think us terribly censorious in the United States, but have you got anything else? So he's obviously getting fed up by now. So the next thing he submits is this. It's nice work of art, but it's his stove in front of it. I can see the kitchen door. I said, well, we like it in principle, but could we have a better quality picture? And so this was actually last month's image on the cover. So it took a lot of work, but we finally got actually a very intriguing piece of art without any baggage, without any baggage at all. So I'm going to actually use this as an opportunity to let you all know that if you as radiation oncologists or any members of your team, your physicists, your nurses, your therapists, are artists, and I know they are because, in my department we have several artists, and you certainly have people close to you who paint or photograph in their spare time. Feel free to get them to submit or encourage them to submit to the Red Journal. We have a steady stream, and we have to reject some, which is difficult. But it's a wonderful way of us as a team sort of exhibiting our human side. And I'll just finish by saying that anyone can get published on the cover of the Red Journal. Even its editor. So this is me in the days when I had hair. This is what I used to do when I was an intern or a resident when things got stressful. I used to go back to my room and sketch either in charcoal or pen and ink. And I still had this picture sort of hanging around in a drawer 40 years later. So we put that on the cover last year. So thank you for listening. I'm glad that I chose not to talk about scientific misbehavior. I'll save that for another time because I think it's a little bit more inspiring. But feel free to submit anything that you do to the Red Journal for its cover. Thank you.